Minutes of the apology and declaration of interest. I've made a cock up on my declaration of interest. We have to declare all our interests, not just what I thought were the conflicts of interest. And so, Private Eye very helpfully pointed this out to me. But I am getting our conflicts of interest, our declaration of interest sort of policy updated so that it's 10 years old, ours. So I will get that done. I thought, Michael, I might get your RGV committee to look at that, please. So apologies for me for making a mistake on that. Everyone else feels happy that they know what the policy is, but I will get it recirculated to people anyway. Minutes of the meeting, everyone happy? Matters arising. I think we pick most of them up during the meeting. There is just one which we said that we would write to the DH, setting out our expectations for legislative independence. This was discussed in the latter stages of the Care Bill over the last sort of 10 days, so we will do that over the next few weeks. Paul, I was wondering whether you might just help us sort of think that through a bit, if you could, particularly in view of the Ofsted discussions over the last sort of few weeks. Would you? Thanks very much. Chief Executive's report, David.
Thank you. Good morning, everybody. So, some updates on progress. First one is the Care Bill. This has now completed committee stage. It's about to go into report stage and anticipate royal assent towards the end of March, beginning of April. Of significance for CQC, it's a very full bill and has lots of significance for others as well. But they considered our role in relation to financial oversight, the duty of candour, and how we assess the performance of local authorities, and that has continued to be an issue. And I've set out in this brief update a report on those issues. So on the duty of candour, this is now introduced. Regulations will be issued. This will be given form by the regulations, and they'll be available for consultation in the next few weeks, and that will see, I think, a bigger debate about this issue, about how it will operate and what the implications will be. On financial oversight, the debate in the committee stage in many respects reflected what the Health Select Committee were reflecting back to us in relation to skills, expertise and experience within CQC in relation to this role. And I don't think any changes were made in relation to the face of the bill, so we will continue to build and grow our capacity in relation to that responsibility. The debate on commissioning, however, has continued to take some form, with quite a lot of energy being directed to this particular issue. The bill as it currently stands requires two Secretaries of State, Committees and Local Government and Health, to request us to carry out a review of commissioning practices as part of a special review. That's using our Section 48 requirements. The energy behind this is really about concerns around poor commissioning, predominantly of domiciliary care in 15-minute visits, but also concerns around the quality of residential care for older people in the main. But nevertheless, it also has implications for people with learning disabilities. Paul Burstow, at the very end of the committee stage, did move amendments in relation to the role that we might play, which will be taken forward. And as I say, I think what we need to do in this is let this settle. I think our position, David, is that if we're asked to do this, we will do this. I think going back to the market oversight, my view is if we needed to do a review of commissioning of local authorities, this would be more akin to the kind of inspections that the Social Services Inspectorate did in days gone by, and we'd need to design and build methodologies that would allow us to do that, and we'd need to think about the skills that we would need to actually carry out that kind of investigation. It's a different investigation to to actually looking at whether the regulations are actually met in practice, because there aren't a set of regulations around local authority commissioning as much as anything else. So it's closer to the work that we're doing in reviewing the health contribution to children's safeguarding than it is to our regulatory activity. So if we're asked to do that, we will do it, and but we'd need to build both the methodology and the capability to do that.
Add to that, I mean, Norman Lamb in particular is concerned that, for example, that a 15-minute domiciliary care visit is not enough. He's concerned that the amount of money being paid for care for people with dementia is not enough to provide. Is that those sorts of issues? But it reflects a squeeze on finances in local authority, in the world of local authorities.
I think it's gone through the committee stages. I anticipate this working its way through, and this will get royal assent. So I think we need to prepare for this with a view to this is something that we're going to be asked to do, not something that will evaporate along the way. Not mentioned in the report, but an update that I became aware of following the development of the report. There was also a debate in the committee stages about whether we could use our powers to issue warning notices for trusts which are going into the special administration regime. And I think what MPs were anxious to do is not get trusts into a double whammy of where we're taking enforcement action, warning notices, and going into the failure regime. Which makes good sense. You can't do both together, it's one or the other. We've previously had discussions with both the department and here, I think, about us having our range of, our palette is the phrase we've been using, of regulatory actions available to us in hospitals. So it's not either you're in the failure regime or you're not, that there's a finer tone required, finer colours required in the way that we actually take forward our enforcement action in relation to trust. If the only tool we've got in our toolbox is a hammer, then it will lack subtlety in relation to what we can do for what we find. So I think this is an acknowledgement of that, but is also not wanting us to actually be using both warning notices, enforcement powers, and the special administration regime at the same time. So that's the care bill. Some updates in relation to the transformation. The preference exercise were over 1,000 of our inspectors and managers had got to state their preference for working in Mike's inspector and directorate, Steve's or Andrea's. That is now complete, and the fantastic position we're in is that everybody will get their first preferences met. Some staff, because in one or two geographical areas and in some of the inspection directorates, we've got too many people at the minute as we start for the original allocations. And therefore it means we've not got enough in some places, so we'll need to smooth that because we've got work to deliver from the 1st of April. But that can be done just by loaning people back and asking people to continue to inspect across more than one sector. Paragraph 3 on this, we've set out what we'll do to recruit over 500 new staff during this year, and as we get that recruitment in, then people can go back to their first preferences and it won't be an issue. Paul's staff in strategy and intelligence going through a preference exercise at the present time. Completed now, is it?
Completed for the intelligence staff, and all but 4 people get the first preferences, though we're just 100% validating that. That's what it looks like at the moment, and we're going through a similar process in strategy and policy. So
that is proceeding well, I have to say. The other important piece of work that's going on now we know where people's destination is and where they're leaving from. We need to make sure that if they're not taking work with them, that work is handed to somebody else, that there's a baton. It's not that they leave, they've got to leave, give their work to somebody, and then they can depart. And that's what we want to see in relation to any regulatory activity, but particularly enforcement activity, and just the process of managing people that are making complaints or sharing intelligence with us about the quality of services which need to be picked up and the risk that we lose vital intelligence because of a discontinuity of people is what we're trying to mitigate with this. The other piece of work which is going on, Hillary's team with PwC taking the lead in this, is a readiness assessment, which is actually assessing our readiness to hit the 1st of April and take on the new methodologies, so we're good to go from that. And that's about making sure that we've got the right people in the right place, we've got the right methodologies, the tools are there, that people have got the preparation in terms of what we're asking them to do. And so the next 6 or so weeks will be responding to those readiness assessments and making sure we've got the appropriate actions in place. On paragraph 3, David, the recruitment, we're flagging up here that there's 3 components to the recruitment activity that we need to undertake, and we're looking to source a recruitment partner to bring in to help us through those 3 distinct projects. That's an attraction and an engagement, and then a delivery on recruitment services. And we've formed a relationship with Penna in relation to that. And then the second one, the assessment design, that's currently out to tender, and that will give us the additional capacity that we need to actually make sure we can get new people into the jobs that we're creating as part of this work.
Eileen, do you want to comment on that at all? I know you're new to it, but you're looking at it.
Well, in essence, as David's outlined, we are facing a volume recruitment challenge, which is we are attempting in 2014-15 to bring in a minimum of 500 new professional people into the organisation to carry out inspection activities and to support in Paul's area around strategy and intelligence. And when you're undertaking volume recruitment of professional people who you want to be recruited safely and securely, and you know you're not going to be doing that every year, it is sensible to seek partners to work with you to make sure that you're bringing people in the right way, that you're assessing them against what your requirements are, that your roles are absolutely properly specified. And that for us, as David's alluded to, where you've got some areas, geographic areas, where traditionally we've had difficulties in recruiting, that we are actually targeting our efforts very specifically at trying to get people into those areas. So that's the rationale behind it. We're pushing very hard on value for money, and also choosing our partners very carefully as well, David.
At 4, I've just shared with the board an important piece of work, which was a survey of the attitudes of providers in relation to CQC and our role. There's a report attached, which I'll not attempt to present, but it covers important issues like the nature of the relationships between providers and CQC, their view about the balance between announced and unannounced inspections. I think the top line message from this is they want an effective regulator, and there's a powerful message about how they define effective. The eagle-eyed of you would have worked out that the interviews didn't take place between June and August 2014, because we've got many powers, but that isn't one of them. So that should be 13. We've got a sequence of these independent reports being commissioned to give us feedback about how people regard us and acting on those lessons that come through from this. This report will go on our website this morning, and by virtue of being presented here will become a public document, and then it's available for others to look at. Not in the report, but only published this week, David, is the Mental Health Crisis Care Concordat. I've referred to this previously, but we're a signature to this, and we've committed, along with just about every major statutory and voluntary organisation working in mental health, to support this Crisis Care Concordat, which is effectively people committing to improve the care and support system for people in crisis because of a mental health condition. Our role really is to carry out the thematic work that we've already committed to in terms of crisis care, but also to look at the collection of data along with other agencies. So there's a fuller report which is available if members of the board would want to see it. We've had some excellent work done by a member of Paul's team with the Department of Health and other colleagues to make sure that our contribution to that can be represented, and we can play our part in that. And then the last, I just want to draw last item I draw attention to appointments. Andrea and Steve and myself have spent a couple of weeks ago some time interviewing, and on adult social care for deputy chief inspectors we've appointed Debbie Westhead, who's currently head of regional compliance in the North region. She covers the North East, as one of Andrea's deputy chief inspectors. Malcolm Bauer-Brown, the current regional director, goes into one of those posts anyway, and Adrian Hughes, who's the current director for the South, because he was acting regional director, has been interviewed and secured that post. So what that means is that we've got one vacancy with Andrea, and we're trying to source that appointment, and that will cover the London area, and will also lead on the market oversight work. On primary medical services, Steve's area, Matthew Traynor is the current London regional director, as you know. And Matthew will take the Deputy Chief Inspector role for London, but will also lead on the work we do around integrated care. Sue Macmillan, who's currently the policy lead in relation to mental health, she will take one of the other Deputy Chief Inspector role covering the North. She'll lead on safeguarding and health and justice, so the inspection roles and responsibilities, which is a continuation of some of the responsibilities she's had to date. That means that for the South region and the Central region, we've still got vacancies. Now, on the Central region, I think we're just in the process of completing the due diligence on an external appointment, but that's not completed, and that person's not given notice to their employer yet, so we're not able to announce that. But that then means that we've got one vacancy for the South, and again we continue to look to secure an appointment for that. So we've been holding on to make sure we only make appointments of people we're confident in, and it'll take as long as it takes to get those appointments in, but we've made good progress on that, and we'll continue to push that. Heads of inspection posts will then go out for inspection, and we'll begin to build those teams. And the contract we talked about with Penna and whoever gets that third contract is really about getting the managers and the inspectors into the vacancies that we've got. So as we work through this back end of the winter and the early part of the spring, that should see quite an extensive recruitment process to bring us up to capacity, although I do think it's likely to be the summer before, if not into the early part of the autumn, before we've got the majority of the people in that we are looking to secure this year. I think that's all of it, David. Thanks.
David, could I just add something briefly to what David said about the study into provider attitudes and behaviours, which is that one of the points that David didn't mention was the finding that there is still anxiety about consistency of judgments in the regulatory system. Now, that is fundamental to the credibility and the effectiveness of a regulator. We do have to insist that and demonstrate that we are able to operate a fair and equitable system of judgments. And I don't want a long explanation now, but at some point I think it would be helpful if the new systems that are being developed by the three chief inspectors could be highlighted to demonstrate how that fairness and equity is being built into the system through a process of moderation and quality assurance and so on.
I mean, consistency is absolutely fundamental, and so I think all the chief inspectors know that. But I think we do need to have a report back to the board about how we're going to entrench a fair system. So can you make a note of that to do that?
Absolutely.
Yeah. Steve as well.
David, I think. So I think the last board asked for a report and agreed it would come in October on exactly that point, but I know Mike spent hours in meetings trying to get the calibration across the ones that are coming so far. So whilst we're doing the live work, we continue to spend time on that. So the point's made. Sorry, John, I didn't leave it out. It was just what I cherry-picked badly.
Just to add to John's point, the other thing that I thought came out very strongly from this paper was across the board providers saying that there's a lot of bureaucracy. And there was one quite alarming quote from a mental health provider about, you know, they think they're probably not improving the service because they're spending so much time on compliance. So again, I wonder if we could just come back to that at some point. There was also concern, obviously, about overlap between regulators, which a lot of providers feel very strongly about. And I really would like to hear quite soon how we're going to mitigate that. That's all right.
In particular, between monitor, TDA, and us in hospital sector.
I do think that you know, the more we can streamline what we're asking for with other regulators, the easier it will be for providers. I mean, the fact that so many people in here had compliance teams, you can see as good or bad. I mean, you know, great, they've got huge numbers of people working on our inspections, but those people could be delivering the service. So, you know, just, and obviously it's not something that we can solve unilaterally, but I do think it would be good to try and keep it top of mind, just given how strongly it comes out of this paper.
I don't know if you could, I mean, you can probably build that in a bit into the work you're doing on strategic measures, can't you?
Yeah, we can, and also there's work that Andrea and I've been doing or leading for the Department of Business Innovation and Skills Review on just this in the care home sector, particularly that overlap between the local authority inspections or compliance regimes and ours. And we've taken quite a hard line on the changes to our model are what should give others a lot more reassurance, and therefore they frankly shouldn't need to duplicate some of the work that we're doing, which will help providers.
Okay, thanks. Lewis.
If I can make a couple of points. The first one is on a similar theme, actually. I was struck in the report by how the providers were talking a lot about managing CQC and their visits. And of course, that could mean lots of different things, but most of them are not very positive. It does suggest that there is still what has hung around inspections of all kinds, not just in health but in education, that there's a sense in which the inspectorate has to be dealt with and presented with a picture, which is what they want to hear about, rather than to get to the sort of reality of practice. And it did strike me that putting that with the fact that some people are saying they didn't quite know what we were looking for, that presumably there will be, the inspectors must be planning some sort of reliability exercise. There must be an induction somewhere in the pipeline which ensures that what inspectors in one place are seeing something similar to inspectors in another, that in one sector and another sector. But it strikes me that maybe the people who are at the moment thinking of managing CQC should be part of that process, so that they also can be, in a sense, you know, inducted into the method as opposed to managing it as an external force.
Yeah. On that point, Andrew, do you want to give your reflection on that?
Yeah. Yes, I think I can. I mean, just to give Lewis and the rest of the board some reassurance about how we are going about that, and we actually spent quite a lot of time yesterday in the executive team looking at two aspects that will help. One is what the lines of inquiry are that we're expecting our inspectors to use in terms of the inspections that they do, and secondly, how do we describe the judgment framework which actually makes it clear what we think good looks like, but also what we think outstanding, requires improvement, and inadequate looks like, so that and you'll see this when we come out for consultation in the spring with the handbooks, and that will be set out, and so that people will see that. And the whole point of that is to be absolutely clear about the 5 key questions that we're asking, which we know are the things that matter to people who are using services, applying our methodology in that way. So actually it's not about dealing with the inspectorate. What we're actually expecting people to do is what they should be doing anyway to deliver a quality service. And so trying to tie those two things together. And then the final point about co-production, which is essentially what you were just suggesting there, that's absolutely how we're going about it. So the conversations that we're having in the adult social care co-production group involves people in the provider sector as well as others who are you know, compliance managers or whatever, who are actually helping us to think through, well, you know, how do you ask these questions in a way that draws out the information that we need to make the judgments that we need to make. But we'll have lots more bites at this cherry.
Could you just comment on that? Do you feel that our team are being managed by some hospitals?
I mean,
the whole issue of consistency probably takes up more of our joint time than anything else. So I can assure fellow board members that we really are devoting a huge amount of energy to it. It is also the most difficult thing. So, and by the time we are looking at a whole range of different core services, and we are looking at 5 key questions on each, and we've got to try and be consistent in the way that we reach judgments on all of those different items. It is tricky, but we are, I think the approaches we've got are to make sure, first of all, that we train the people on the inspection teams, our own inspectors, the team leaders, and the external experts that are coming to join us. I think we have to have absolutely clear guidance, as Andrea has said, about what constitutes good, so that they know that. And then, importantly, certainly at least in the hospital sector, where we've got relatively smaller numbers than either Andrea or Steve have got, all the reports are coming to a National Quality Assurance group. So we are reading each one and trying to make sure that we are being consistent. And it is one of the reasons we decided not to rate the first 18, because we were absolutely aware that there were difficulties here.
Thanks very much, David. So also on the report, a couple of things which struck me, one of which was this preference for unannounced inspections, and the other was the desire to identify more clearly what the CQC requires, and so that people could and what was required to fulfil those requirements. And it strikes me about both of those that they go to the heart of what we want from well-led organisations, that actually responsibility for understanding and interpreting what the standards require is something that one would expect leaders of the organisation to wrap their heads around and make clear to the organisation, and that there's something about unannounced inspections. I mean, they absolutely have their place, but of course one of the reasons why people are expressing a preference seems to me to be because they want CQC to perform their own kind of internal audit stroke quality assurance functions for them, and that clearly is not what we're there for. We might coincidentally be helpful in that respect, but it's not the primary purpose of our inspection regimes. And I suspect, so this is a hypothesis, but I suspect that both of these are issues, if these are reflections of larger organisations, I think our answer is, well, this is about well-led. But I suspect that these are two things which will crop up, particularly for some of the smaller organisations where they don't have big compliance functions, and actually our visits are an opportunity to help them get things right in many respects. And I just think at some stage, I mean, and that's something I recognise from other regulated sectors, the small organisations have very particular issues, and I just think at some stage we need to take the opportunity to look at small organisations across our kind of environment, and see how their needs are different and their interests are different, and whether we need to flex our approach with regard to them. Probably not immediately. I mean, it will particularly affect Andrea's area, but it will affect primary care in a big way as well. So it's not just a social care issue.
A couple of issues. In terms of kind of defining what good looks like, I would urge caution from previous experience, because there's a tendency for providers to sort of pressurise us into being absolutely explicit about what they need to do to be good or outstanding, okay? And they could put all effort into that, but actually it doesn't necessarily translate into good or outstanding care on the ground. So I would sort of hope that we would be, although we could give some clear statements, I would be very cautious about being very explicit in what that looks like. And the other issue is about the care bill on commissioning. Now, it's been a hot topic for a long while, and a lot of people want us to take back assessing commissioning. And my sense from what how David presented that issue was that we would take it if it came our way, and we will prepare for it. And I just wondered if
we need to have a slightly different stance, you know, that actually, yes, we do want to take it because it does have a particular impact on quality, but also the capacity to improve, because providers sometimes are affected by the quality of the commissioning and so are constrained in how they can improve. Now, I don't know, you know, there may be parameters about how or if we take commissioning, but I just wondered if, you know, just waiting to see if we are asked to do it, but sort of making some preparations was a sort of the ideal position for us to be strategically, or whether we need to make a firmer stance on it.
Good point. Well, both two good points there about making our definitions too specific, because then you get into the whole, we hit the target but kill the patient sort of syndrome. So on the commissioning point, I mean, I don't know whether, I mean, my own view on this, I don't know if it's shared, is that we should be actively seeking to look at the quality of commissioning from local authorities. Does anyone disagree with it? You disagree with that? No, okay. Yeah, okay, well, so that's your point, I think.
Can I just recall that I disagree with that?
Just David, just before you do, John, yeah.
Well, sorry not to cut across. I'm not noted for sitting on the fence on this. So if you look at adult social care commissioning, nationally, my calculation is about a third is commissioned by local authorities, a third is commissioned by CCGs, and a third is commissioned by self-funders. So if you really want to have a go at the regulator contributing to raising the standard of commissioning, then my view is you need to do it across commissioning and not do a partial review of commissioning. So my only point is, I think there's some first principles that need to be thought through. I was trying to say, okay, I think this is coming our way and we'll do it, but we ain't got the skills in here to do what we're being asked to do at the present time, and we'd need to build them in. So I think there's a pragmatism by what I was trying to do, and if I didn't quite get the principle bit, is let this be evidence-based policy rather than responding. So we've just looked at what providers have told us about us, and we've said, well, let's listen to this, but also sift it as well. Well, in the same way, I think we need to sift what providers are saying about it's all down to commissioning. And we need to apply some judgment to whether it's all about commissioning in the way that we do that, rather than saying, yes, that's right, let's all do it. Does commissioning have an influence on quality? You bet your bottom life it does. Is it the only influence on quality? No, it isn't. And therefore, I just think we need to be really clear where we're treading in relation to this. And also, when we see something that is poor or good, that we're clear what we can do about it. And at the minute, the only thing we can do is shine a light on it or use a bully pulpit. There's no other action we can take, and I just think we need to. So that's why I think the policy in relation to this needs to be really worked out and set out, so the board can make a judgment about how we're going to do that. And you might as well have been listening to the executive team yesterday on exactly this point about what the risk of defining everything in such definitive terms that people, to go back to Lewis, play the system and game the system rather than do the right thing, which is deliver quality.
I don't think it is coming our way. I don't think local government will have it. I don't think the DCLG will have it. A compact has been constructed at the last by this government with local government, which got rid of the Audit Commission, which was a bigger beast than us. And I think it will. If there's a joint lock on this from the DH and DCLG, I think it won't be coming our way.
Can we be quite quick?
Yeah. It's just I was in the middle of my previous point.
Sorry.
You
have to speak quicker, faster then. And I won't interrupt.
I wouldn't need any gaps this time.
No hesitation.
On the report of provider attitudes, you said that there might be other similar reports. I just wondered who was meant by providers in this situation, because presumably it meant the management of the trusts primarily, because there obviously are other views within a trust about the inspection process. And I'm carrying around with me a concern about clinicians and their views of what we do and their scepticism. It just so happened that after we had our first wave, by complete chance, I was sitting next to, at an event, somebody, a senior clinician in one of the trusts that Mike, your team, had inspected, and he claimed not to know. Now, he may have just been saying that for my benefit, but it goes to the heart of something broader, which is about whether clinicians feel engaged in this process, and it's essential that they will. I'm sure you have that in mind, but it's essential that they do. Very quickly, the mental health crisis concordat is a very important document, actually, and it's done very well to broaden out what started as a concern over the use of police cells for people as a place of safety for people who are detained by the police under the Mental Health Act. That is actually one important but actually quite narrow issue against a much broader background of problems in mental health crisis care. You didn't say that today the CQC has launched an online consultation with patients and carers and staff about this very issue, so that feeding into our thematic review. So it is a big issue in mental health, probably one of the biggest issues. And if I've just got one lesson, can I? We are guided, of course, in these discussions by what, David, you choose to highlight, which I think is very helpful, and it helps direct the comments. But sometimes things are happening off stage in a way, or in somewhere else, which also need comment. And the last couple of weeks has seen quite a bit of activity in Bristol on children's heart surgery, and now an investigation into it set up by NHS England. And I know that's not us, but is it possible for us to know what is the process through which something like that has happened? This is, after all, the place which had the previous scandal in 10, 15 years ago. What's been our involvement in this? What should have been our involvement? Why NHS England and not CQC? And I need to try and understand what it is that has led to the next phase of the Bristol story.
On the first point, the clinician engagement point, I'm hoping that the clinician didn't know what was going on. I've met a lot of clinicians who do know that it's been going on, but it's interesting to get that observation, because we don't have clinician engagement in our inspections, then we have got an issue there. I mean, Mike, what's your observation?
My observation is you can tell me afterwards which hospital it was, and I will tell you whether we thought that there was clinical engagement in the whole process of running that hospital, because that is one of the things that we are observing. And so I don't think it's just a question about clinical engagement with our inspections. I think that we undoubtedly observe variations in clinical engagement. I can talk more about that at length.
But just on the point about this is getting feedback from providers as distinct from clinicians. I mean, can we get some feedback from clinicians as well? That's your main point, I think. No, yeah.
Of course we can. And the other thing about comparing this take my flippancy out about the date. This was June to August last year. We were not running any of these new. Mike hadn't been in the building for more than 3 weeks when this started. So there is a sense where this paints a picture of what was rather than what is. But the key issue for this, notwithstanding your point, Lewis, about what selectivity goes on in the issues I'm raising here, is we're committed to making transparent the feedback we got. Having got this independent report, it was appropriate that we publish it, and we're seen to actually draw it to the board's attention. So we'll continue to do that, and we can look at clinical engagement. But I'm with Mike. Actually, it probably tells us as much about whether the clinician feels engaged in the hospital he's working in as ours. The 3 inspections I've done, I've spoken to clinicians, and they definitely knew we were there.
On your second point, I mean, I think where there is a story like Bristol, for example, it's a serious issue, and okay, where are we in this, and where's Bruce Keogh in this? I think just a note, David, to the board during contemporaneous note will be helpful, or from you, Mike, if there is a big issue like that, will be helpful.
David, it of course was in David's weekly issues. Although I think David had written that before Bruce Keogh had actually commissioned this new new report, and I think that was the disappointing part, that the CQC wasn't asked to undertake this new review. He asked somebody, you know, apparently completely independent, to do it. So I think David does pick up on these things, but I think that I think in this particular case, events had moved on after David had written the issues paper, which I think on the whole is an excellent document.
Mike, on the point about us not doing the investigation, I mean, the history here, Mike, is that Ian Kennedy, who is doing the investigation, did the original investigation at Bristol, was it 10 years ago? Yeah. So there was, I think, a pretty strong logic to get him to go back and look again. Is that fair, Mike?
Yes, I mean, clearly we have known about the deaths that occurred at Bristol. We have already looked at a whole range of the issues behind that. I welcome the fact that there is going to be a further detailed review and that Ian Kennedy is going to do it. We will liaise closely with Ian Kennedy on that, and we've already saying that publicly this morning. I think we also are having a meeting later this week in Bristol with all the relevant parties to make sure that we are working together on this. And just to reiterate something that Bruce Keogh has said, he has looked very carefully at the data on mortality from Bristol, and what he's saying about that is that they are bang in the middle of the mortality range for children's heart surgery, for the range of procedures that they undertake. But we are following that very closely and working closely with them.
Thanks very much. I think we should move on unless anyone else got a burning issue. Thank you. Steve.
Thank you, Chair. The report is for everyone to see. Just to briefly come back to consistency, we had a 3-hour meeting yesterday morning with the British Medical Association, which was looking at consistency as the main topic we were talking about. And prior to this meeting this morning, another meeting talking about how we build in training and support and quality assurance underneath the umbrella of the academy within CQC for all of the GPs and inspectors, which we'll take on with Wave 1 starting in April. I'll keep this report brief. I just want to focus on the update on the out-of-hours Wave 1, which is going to plan. We've had to postpone one inspection of an out-of-hours unit because of the flooding in Surrey, and we felt that adding an inspection on top of a very stressful time for all of the clinicians trying to provide care would be unreasonable. And going back to the last board meeting where Paul was extremely helpful about the responses from clinical commissioning groups to our requests for information, that was covered in the Health Service Journal. Thanks to them, we now have 9 out of the 25 CCGs who've responded. So given that our review doesn't just look at the providers of out-of-hours care, but also looks at how that care has been commissioned, or whether they know what they're commissioning, and that relationship, because that was part of my 2010 ministerial review, 9 out of 25 is still not good in the time they've had. But at least it's better than nothing. And we will be reporting in April as a first report. But the reviews of out-of-hours continue right the way up till Christmas. We're making good progress. We've had training sessions. We've got at least 8 half-days and days of quality assurance and consistency meetings, because we're learning from this on how we apply Wave 1 to in-hours as well. Thank you.
Any question for Steve? Okay.
On the sort of developing the new approach to inspecting primary care, are you sort of involving and collaborating with patient groups in developing that? For example, I know there are some sort of local Healthwatch, for example, that have done work in GPs or for GPs. You know, in terms of sort of co-production, is it also with patients and the public?
There are 2 aspects to that, really. Right away from the start, we've said that using patients, the public, and making sure we reach out to groups which health services don't tend to reach out to the homeless, different, particularly minority ethnic groups too, is going to be important. But collectively, across the 3 inspection directorates, we've agreed that Chris Day in Paul's team is doing a review of experts by experience and how we consult and work with the public. Because for me, it's not just about general medical practice, it's about the integration and feedback. So the answer to the question is, we're doing a review of that led by Paul's team. As we start to work forward looking at in-hours, then input from those groups into ratings, into how we do our work, is absolutely essential. And as you'll be aware, with another hat on, my last role, we're just completing a review of transgender healthcare across England, and we've been very keen to work with that community, who often have poor access and variable access to healthcare, to see how we can improve what we're doing and the questions we ask. The last 4 months has been set-up mode, and we're just starting to get now a team to do work on what you're suggesting.
Just sort of worried that we might sort of miss the boat in terms of patient and public engagement when in the sort of set-up phase. So.
Thank you. I'm sure you won't let me miss the boat, and it is absolutely core to everything we're doing.
Just on case point, and then more generally on Chris Day's review. So, I mean, I think it's fair to say now that Healthwatch England are kind of locked into the groups that are sort of helping to develop the inspection regimes, and we've obviously got a very clear eye on how local Healthwatch will play into those. I think it's fair to say, I don't know what Mike would say, but I think in relation to hospital inspections, it's been a kind of mixed picture at both ends, both in terms of local Healthwatch's ability to engage and actually for the inspection teams to and the sort of whole process to remember to engage them. So sort of, you know, learning as we go. But that makes it really important that we retain a sort of an eye on how that will all work across all 3 inspection regimes. And I just before you take the mic, Steve, on the Chris Day engagement review. I think it's really important. So I've talked on a number of occasions about the fact that I think there is a need to reflect on the way that we involve and engage the public, particularly, I mean, generally, actually, at the CQC, but particularly in the context of the new inspection regimes. So I'm really glad that the review's been commissioned, but I would be really interested to see the scope and nature of that review. I mean, I think experts by experience are a tremendous and very kind of well understood success of the past. But they are not the be-all and end-all of the way that we should engage and involve the public. So I think there's a kind of much more expansive review that we need to do. And to do that well, at CQC, we'll need to engage with a range of people who have done a lot of work in this area, and make sure we draw on that experience and learn from it. So I really appreciate sort of sight of that, and I guess for Healthwatch England in particular to be closely involved in it. But I think for the board to have sight of the scope of the review would be a good thing.
I know Chris would be very happy to know there is a day review. It's more that it's his day job, without making the pun. So as a director of engagement, so firstly, the experts by experience piece of work is absolutely, and as you say, set in the context of all the different ways that we need to engage with the public and people who provide services. And although experts by experience is one element of it, it is only one element. So Chris's job is to solve that piece of work, and I'll make sure that you get a briefing on where that's up to overall and how we can engage better with Healthwatch. The specific piece of work that Steve was alluding to was, as we have a series of contracts coming to an end with different providers of our experts by experience programme, we're looking at whether we're making the right decisions for the future in our new approaches in the way that we procure that, and frankly whether it's an important enough aspect of our work, whether it's something that we should be fully outsourcing or bringing more in-house. That's the big piece of work to be done.
David, sorry, can I just come back on that just for a second? So that's very clear, and reminds me that we had a conversation previously about the potential increased demand for experts by experience and how we manage that, which I understand and I know we need to do. I would like us to do a review of how we engage and involve the public in our inspection regimes, and more widely, and it is probably a separate exercise, in how we do this in CQC. So if this isn't a day review, can we please think about how we might do such a thing in due course, because I think it is required.
And this is just specifically around patients and out-of-hours services, because and without pushing the point, if the CQCs don't know who's providing the service, it's pretty likely the public don't. And actually, the failure of this service is causing one of the biggest crises in the National Health Service in terms of emergency admissions, etc. So it's quite difficult, because actually we need to engage with the public about their non-engagement. We need to know who do you the questions around who do you phone, does such a service exist, those sorts of things. And I think we'll find that for lots of people the service doesn't exist, and that's probably one of the most important findings. So how you find that, I think, is a different sort of, it's engaging about non-engagement.
Okay. On that, I'll come back to Anna then. On that specifically, we're pretty sure we know who's providing the service. There are some instances which we will get to where GPs have elected to do their own out-of-hours, who are then asking us as a subcontract to provide the care. What we're doing as part of this review is making sure we are absolutely certain on our database, because coming into this with a history, I've got unfinished business on out-of-hours, because I think it's an area of risk, and we're making progress, but it's disappointing that when we ask for information it doesn't come back quickly, and that's a learning point for all of us, I think. I think Anna's absolutely right on the work. We're working very closely with Paul's team, led by Chris, and I'm learning as well, in that my original thoughts for how we engage with the public, as we've spoken about before, were based on the new primary care model of going into each CCG every 6 months and having a presence. The more we learn, particularly from Mike's experience of hospital visits, how they engage with users of hospitals, it's becoming more obvious that the drive will be in localities, so that you'll be able to build up over a rolling time information from local users of the service and the public, of which Healthwatch, I believe, has a really crucial role. But that also means it will have a knock-on effect for how you consult on a service, and how actually we timetable our GP inspections, so that we start to integrate them more with looking at local care services as well as hospital and mental health. And so as we start to build our team and look at this, we actually are working very, very closely with Chris Day and his team on how that evolves. And we've not done very well with engaging the public in out of hours, because if you advertise even on local radio, please come and talk about your local GP out-of-hours service. In Birmingham, we had 0 people turn up to an event that we held despite local publicity. And in Bristol, there were fewer members of the public there than there were members of CQC. Now, I say that because I want to be open and transparent and look at the different ways of engaging, of which we have to do better. And when you talk to the public about out-of-hours services, those who haven't used it don't know what we're talking about quite often. Those who have used it find it very difficult to access them. At the moment, with 111 or ringing a GP and getting an answer phone, there's still inconsistencies. But all of these things we're finding highlight the importance of the review that we're leading on, and I would anticipate that in the probably the May, hopefully April, but May board meeting, we'll be able to share some of our findings.
makes my point. I mean, the NHS is providing a service for 50 million people that nobody seems to know about, which actually seems to be a real problem. And you're quite right, engaging with people that don't know about a service is not likely to happen, but it still is a really crucial issue. Because people don't know about it, they go to A&E.
And my final point, Chair, and I did promise you I'd be brief, and this is brief for me, I had a very good discussion with Cliff Mann, the president of the A&E doctors, the emergency medicine doctors, and I'm just looking at how we can engage more, because I think the model needs to evolve to how we look at urgent care in areas rather than just one particular part of it. And what I'm looking at is how we get regularly feedback from the emergency departments on out-of-hours services, because we know in 2 parts of the country from local GPs, they're telling us that in almost identical rural areas, the A&E attendances are higher in one area compared with one just up the road, because there are more doctor triage and contact with the patients who ring for advice than in the area just south. And I think we'll find some really interesting things beyond what I'd thought about before. But also, if you go back to our ministerial review, I still want to satisfy myself that the performers list is working, that providers are interviewing doctors who are working in the services, and they have methods of quality assurance. And until I'm satisfied with that, I won't be.
Very, very briefly, I'm becoming concerned about GPs charging for care home visits. CQC did a report on it a couple of years ago and thought that about 10% of GPs do that. And the Sunday Times is actually looking at that and discovering that's probably more. And I just wondered where that was going to sit, because it seems to me pretty iniquitous, because all those people, GPs are still paid per capita and they're still getting the money. And I think there's quite a lot. I just worry that there's an issue there, and I just wondered where that would fall across our various sort of departments.
Thank you very much. It falls very well with all of us in here, actually, and we are just in the middle of correspondence with ministers who've raised this issue with us, and the answer to the question in a legal terms are: general practitioners like myself cannot charge for GMS services, but within the regulations, I can't remember, section 5 says you can, above and beyond that. What disturbs me more than the regulations, in a way, because I can see the need for many local area teams are talking about local enhanced services for providing extra care to care homes. In some areas, the care homes and nursing homes provide what were hospital care above and beyond GMS. I am disturbed by some of the newspaper reports about GPs refusing to take on patients from some care homes unless they get a fee. That is completely wrong, and we will look into that when we start to do our inspections, and are already trying to pick that up before we move to the new model. And I share your concerns.
Just to add, because it is a shared responsibility, I think, between Steve and I around this, and Care England, the trade association for some of the larger providers, released information earlier this year, which was really highlighting and may well have kind of piqued the interest of the Sunday Times as well around this. And Steve and I are working with each other to respond also to Care England and to pick up on the good practice guide that the Social Care Institute for Excellence has recently produced, which actually enables care homes to have a firm basis for kind of some of their discussions about what support is actually appropriate in a care home. So we're kind of trying to deal with this on various fronts, Camilla. Leading neatly on, thank you. You've got the report, and to be quick, as we're running past time now, I'll just highlight a few things. The first is just to reassure Kay that we are indeed co-producing with as many people as I can possibly talk to in the development of the new approach, and the policy team sitting with Paul and led by Rachel Dodgson has been absolutely fantastic in working with me on that. But one of the things that we are thinking about is how we use that information from people, from the public, people who are using services, families and carers, as part of the intelligent monitoring for adult social care. And that obviously includes linking up with Healthwatch, local health watches as well. And so one of the things that we're exploring with the Think Local, Act Personal sector-led improvement partnership is how we can link with the work that they are doing on building community capacity to look at how we kind of make all of those dots link, so that we're making the best use of some of that more qualitative information that can help us to understand what's happening in the social care sector. The second thing I wanted to highlight was the Wave 1 inspections for adult social care, because there's a lot of activity going on with that at the moment. We're in regular correspondence and liaison now with the services that will be included in the first wave, both identifying those and also working with them to get some information back from them, so that, for example, in the community services, we can actually proactively go out and seek views from people who are using services, but also healthcare professionals and others who may have views on those services to feed into the inspections before we go. So there's a lot of activity going on there. We've identified inspectors who will work with us on that first wave, so that we can, really focus on the learning that we need to do in testing our approach once we start on the 1st of April. And that will feed into the evaluation that we do of that. And again, teams in Paul's section, Christina Cornwall is helping us with this, to look at the questions that we need to ask both of providers, but also of our own inspectors in terms of how that goes. We know that we are going to be learning, and our volumes kind of give us a real challenge around consistency, as everybody has spoken about. And so although we will be looking at how we would rate a service, we will not be publishing ratings for that first group, because I think it could be misleading for the public and people using services, and potentially unfair for providers when we really cannot be guaranteed of the robustness there, but we will use that learning. David's obviously already stolen my thunder around the announcements of the new Deputy Chief Inspectors, but I'm absolutely delighted that we've made such a strong set of appointments, and really looking forward to working with them. We'd just like to record that. Thank you.
Any questions for Andrew? Lewis.
Andrew, could you just say a word about Winterbourne View? There was a CQC sponsored a meeting last week about the progress under Winterbourne View, and it was an absolutely unforgettable meeting, actually, which I sort of chaired after a fashion. But in fact, the leading performances were the families who weren't specifically from Winterbourne View, although one was, who came to talk about the experience of failures in the care of their family members who had learning disability and who were in institutional care. And the ramifications are very broad, because they're about the care system, but they're also about the Mental Health Act, they're about the standards of the doctors who were doing the assessment. There's so many issues which these cases raise that it's just very important that we don't lose sight of this as a body of work. I just wanted to get your view on where the next what the next step might be on that.
Thank you. Mindful of the fact that Winterbourne View was indeed a hospital and an independent hospital, and actually in terms of the inspection regime sits with Mike, but in terms of the issues to do with regulating, inspecting services for people with learning disabilities, that's a shared responsibility between both of us, supported by the policy team sitting with Paul. And I think that the the thing that Mike and I are absolutely at one with each other on is that we learn the lessons from this. We learned the lessons from Winterbourne View in terms of what happened there and how CQC responded to that and what we need to do in terms of our inspection and regulation regimes. But equally, we listen to the voices and we take to heart, if you like, and I absolutely do, take to heart the experiences of those people who have used those services or had loved ones in those services and have been failed by them. In terms of the specific event, I mean, I've spoken to Alan Rosenbach, who helped to organise that, and I've met with, and Mike and I met with Viv from the Challenging Behaviour Foundation, and I've also met with one of the women who talked about her story of her son at your meeting last week. And I think that, you know, as in any of these things, it's actually hearing those personal stories that really, you know, reminds us why we do what we do and why we need to do it as well. So we will continue to work with, and I know that there's going to be a write-up of the day in terms of the issues that were raised. I'd previously spoken to Sarah and had identified some specific issues that she'd raised with me that we need to feed into the methodology that we've got as to how we ask questions and the things that we should be looking at. And I know that Mike's got some very specific issues that he's going to address in terms of how we look at the services that are provided for people with learning disabilities across all of our sectors, including hospitals. So you can be absolutely guaranteed that, you know, a one-off event is not going to be such.
What was your impression of it, Lewis? I mean, what did you take away from that meeting?
Well, I took away a concern, I suppose, first of all, the people there who were presenting the stories of their families had yet to be convinced that the system would change, and that wasn't particularly directed at CQC, although they had some criticisms of CQC. They clearly felt that the fundamental change in the provision for people with learning disability they hadn't seen it. And I suppose my concern was that there were so many elements to what went wrong. I mean, there were not an infinite number, but there were several things that went wrong, which has to be remedied by, you know, the Mental Health Act Code of Practice, but also by the professional standards of psychiatrists, and who is determined that because somebody was re-sectioning, re-detaining these individuals at Winterbourne View, and therefore presumably approving their care plans without, and these were unapprovable care plans, and yet they were being approved. And so, you know, it was partly about the question of residential care versus community provision for people with complex needs. That is obviously at the heart of it, which is why I asked you about it. But there are these other elements, all of which adds up to a package of transformation. And unless we get all of that right, I think we will not win the confidence of the people who've been affected by it.
I mean, and if I may, David, I mean, I think that CQC has a role to play, and we are committed to playing that role. But it's a role to play in a system, and actually working with others is absolutely critical with this. And one of the things that's happened very recently is the Joint Improvement Programme, which was established after Winterbourne View, has just gone through a change of leadership. And Bill Mumford has now been appointed as the director. And one of the things that I think that we do need to do is to work with him, as well as working, and Lewis is absolutely right. I mean, the kind of some of the professional aspects of this, you know, go to the heart of, you know, what do mental health professionals do sometimes. We have to work across the system with those other people to make sure that every lever that we possibly can pull is pulled to actually make the difference, which, you know, I mean, I've sat down and listened to some of those stories, and, you know, frankly, they make me cry because it just is not what should be happening. I mean, not in this day and age. And we need to make sure that we make those connections, and we kind of push from the side as hard as we can.
Oh, I've got a second. One of the, you asked my impression. One unforgettable part of the impression that day left was of what happens when the system hasn't got the right provision for you. And what happened to some of the people is that they ended up in a place which was unsuitable. I don't just mean Winterbourne View here, actually, it is more than that. They end up in a place that's unsuitable, and then, because that place doesn't suit their needs, they end up behaving in a way which confirms to everybody that their needs are greater than they thought, and therefore they become more embedded in a system which was wrong from the start. And the first question was whether or not they are being properly placed or whether properly provided for, whether their needs have been understood. And of course, there was one of the most impressive stories was when somebody was in fact taken out of effectively the wrong residential care system and was now living independently in the community. And honestly, you felt like cheering at the end of that. It was such a powerful narrative about somebody getting that at every stage that the incorrect provision was being compounded by the reaction of everybody who said, well, there you are, you see, we knew that this was that she was a person who wasn't going to cope in this environment. We need to do even more to restrict her and contain her problems. Actually, what she needed was to be in somewhere else. And that element, I think we do have this is part of the problem, that a lot of people are responsible for putting this system right, but we have a leadership role.
David, yeah.
Well, this is the point that I want to make. I do think we have a role to say this is the wrong model of care. I thought we were closing down hospitals for people with learning disabilities, not opening them up. And I think this plays to the commissioning point. Why were these commissioned, and by whom, and why? Your point about the professionals, Lewis, I think is absolutely spot on. I think that's been one of the quiet things in the narrative about Winterbourne View. There's been a lot because CQC came out and publicly apologised from the beginning it had got it wrong. And there's been a deafening silence from others about what their role in that has got to be, in my view. But I think this plays to the earlier conversation which was going on about how we engage with the public and the public that we can't engage with. But this is absolutely the reason why we should be listening to the voice of people using services. And I think one of the things that we've been doing over the past 12 months in particular is really exposing ourselves by holding those events. I hold monthly leadership events. We've just completed our second major conference where we had 300 people together. And we are pretty determined not to have any of those events without having the voice of people using services beginning or making a contribution to that day, because it's a leveller in terms of reminding people why we're here. So I think there is a bit about building in. Paul uses the word rhythm of our organisation. I think we should build into our organisation a rhythm which doesn't allow us to do some of these big set pieces without having the voice of people who use services or their carers in the room. Because it plays to the point about how we know what users and carers are thinking of us, how we know what our stakeholders are thinking of us. And I think the care bill does give us, in terms of fit people and the changes to our registration responsibilities, in my view, it gives us the ability to say, I don't think this is a good service. We should not be registering it because it's actually not meeting needs. Now, that will take us into an area where people will be really, really uncomfortable. But who gave planning permission to a care home in the intersection of a motorway on an industrial estate? So I think we need to trace this back about how do these things get commissioned, how do they get built, how do they get funded, why do they continue to be used, who keeps reinforcing them. And actually the bit of the system that we can influence is that bit about why did we register it? Why did we think it was a good model of care that we thought we could register a hospital? So I think your challenge as a board to us has got to be about what are we registering and why? And that's one way we can get at our leadership responsibility. And somebody, we're going to have to say, I'm sorry, we don't think that's a good. Yes, you've got all your finance in place. Yes, that's a good registered manager. Yes, you've got all those things. But are we not convinced this is the right model of care? And then that will be a fascinating discussion, but ultimately that's what we will need to do, I think. So you're absolutely right to challenge us in it, but we must keep listening to the voice.
Just very quickly, I mean, these services that are commissioned are extremely expensive, you know, and actually they need some sort of courage somewhere to have a very clear plan to redistribute this money into the proper services, often in the community, because they are so expensive and yet they're not delivering outcomes, and we need to be careful that we don't continue to perpetuate that model, but also to engage more widely, because it does require some courage to, you know, take money out of these services that don't really deliver, to try to get them into where they're actually, you know, the money could actually be more effective and useful to people.
We haven't got time to do full justice to this. I'm just saying I'm very glad you raised the issue. Could you circulate the notes of the meeting that Lewis referred to the board if they would like to see that?
Yes, I'll follow that up with Alan. Thank you.
And can we come back to this, David, in a month or two's time? 'Cause I'm sort of left with, there's a big issue here and it's sort of hanging there and we're sort of responsible for it, but what's happening? So can we come back to it? We've got more time.
We can, and what we'll try and do is map out what the other contributions are. Norman Lamb is chairing a group which is looking at what the commissioners are doing, what others are doing, and what we need to do as our contributions to that. So if we try and bring a report which actually goes through what the contributions are.
Okay. Mike. Thank you, Andrea. Mike.
I'll just give quite a quick report. Things are moving apace in the hospital sector. For wave 1, which everybody knows, we had 18 trusts in that wave. That's completed before Christmas, and the reports are now all completed as well. The whole issue about consistency and getting the right, well, it's partly about getting the right teams, but it's about the consistency of reporting, are very live in our minds, and we are sort of reviewing the whole of that wave at the moment, and we are planning to publish an overview report in due course, hopefully in March. Since then, we have moved on to wave 2, and there are 19 trusts acute trusts in wave 2. 9 of those have now been inspected, but none of the reports have yet come through. That means that we have done a total of 27 of 161 trusts in the country, which actually means we've done 1 in 6 of all trusts in the country. We have at least inspected them. And the new ones that we've been to are Leicester, Blackpool, Northampton, Royal Cornwall, Hull, Morecambe Bay, Homerton, St George's and Heatherwood and Wexham Park. In wave 2, we have incorporated changes and lessons learned from wave 1. For example, we now have a conversion program for our own CQC inspectors, so that they are getting trained in the new approach, and over 100 inspectors have been through that program. I'm sure there will be need for more training, but that is at least a start. With Paul's team, we've been working very hard on the question of what good looks like, and the guidance that we can give to providers on that, and also obviously to our own inspection teams. We've juggled around the time we use on site to a degree, so the chief executives of the trust we're providing give us a presentation on what we call day naught, the training day, so that we get a flavour of what is going on in the trust from their perspective before we go and look for ourselves. And we also hold the listening event with the public and patients on that the evening of day naught, so that can inform the whole of our inspection. We've tended to bring the focus groups with staff forward in the inspection, and the interviews with management, put them later in the inspection, because the focus groups are effectively data gathering sessions. The interviews we can then challenge back to the trust with what we have seen and what we have heard. And another a change for me is that after these inspections, our new heads of inspection are sending me very soon after the inspections at least their headline views of what they found at the trust. That gives me an impression of what's going on there, because obviously at this stage it's no longer possible for me to go to each of the inspections myself, but I do get a very good flavour from those immediate responses. Going beyond the acute hospitals, I'm very pleased to say that the mental health and community service inspections are now underway. They are wave 1. We have now done 4 pilot inspections. 2 are for community services, 2 for mental health. They are Central Essex, which is a social enterprise, community health service, Coventry and Warwickshire, which is mental health, Bridgewater, which is community services, and Devon Partnership, which is mental health. In addition to that, one of the acutes that we've done on this wave is St George's, which also has some community services involved. So that's a combined look at acute and community. I think what we can say at this stage is that the broad approach that we've developed for acute inspections can be applied and adapted both to mental health and to community services. Clearly there are differences. There are differences in the actual services we're looking at. There are differences in the travel required. Lewis, we're very well aware of the size of mental health trusts and the geographical patches they cover, and so we are not only looking at the inpatient services, but we are travelling around to look, for example, at crisis teams in different parts of the patch that they cover, and the same on the community services, visiting not only where district nursing teams are based, their locality bases, but actually going out with the district nursing teams and seeing how they do their work. And we are also speaking to patients who've recently been under the care of community services to get their views on care. And this wave of mental health and community services, we're now just about halfway through it. That will conclude before Easter, and I would again hope that we will be able to publish some form of overview report probably by about May. Just finally to say that 2 of my Deputy Chief Inspectors have now started, Andrew Gordon and Paul Lelliott, and that's extremely welcome. And the other 2 have been announced, and they will. Ted Baker will start in the middle of March, and Ellen Armistead in the beginning of April. That will also be very welcome.
Thanks, Mike. Michael, we've had 3 reports from the Chief Inspectors. Any observations?
Well, I think they are 3 excellent reports. I think the question that I think in a way runs through all of them is, and it was touched on when we discussed the admittedly pre-new regime research into what providers think about the CQC, is this question of standards, and especially is the CQC setting minimum standards, and are the standards it set, if they are minimum standards, high enough? I think is a sort of consistent theme, and I think it is something which the CQC, I'm sure the executives are concerned about this. In the CQC's definition of purpose, it does say high quality care, and yet there are clearly some providers who think that the CQC is inspecting for basic standards of care. So, and this applies across all the 3 directorates. I think getting a strong understanding within the CQC and outside the CQC of what we mean by high quality care, I think is very important, as I say, as in a way a consistent theme across the 3 reports, even though they've been focused on the individual areas.
Any other comments on Mike's report in particular that people like to pick up? No? Right. Thank you very much. We're coming to you much more in the private session, actually, in terms of, as you know. Paul.
So this is the Q3 Corporate Performance Report, and it's a sort of twin paper, if you like, with the complaints report, which Eileen will present. In the interest of speed, if I just point to the pages 1 and 2 in terms of the overall highlights, rather than going through each of those bullets, and similarly on the areas for improvement. But if I just pick out 1 or 2, on the it's worth saying our enforcement activity has significantly increased in Q3 compared to Q2, so 410 case enforcement rather than 353, similarly up on Q1, and that I think highlights some of the board's earlier discussions about the need to look at this area, and it moves on to the other issue you'll see picked up around people who've been non-compliant for over a year, and a number of actions that we've taken against that. The first thing to say on the numbers haven't decreased in the last quarter in terms of those who have been non-compliant for over a year, and that's why we're particularly targeting our resources on those. We have issued 136 fixed penalty notices for providers who haven't had a registered manager for over a year, and although that's clearly a difficult message for providers, there's good evidence that that's increasing the number of registered managers in services, which we know, particularly in care homes, is linked to high quality care. We also have good evidence from the provider survey that providers are increasingly confident in the work which we're doing, which is a positive sign, and I think plays to some of the discussions we had earlier on the ResearchWorks research. If I just turn briefly to the finances, these are very similar to what you've seen before. There's a slight predicted underspend on the revenue side and a significant underspend relative to the beginning year budget on the capital side. But I think the 2 points to say there is that we always set out in the capital budget potential maxima, and given the amount of design that we've been doing over the year, I think it's probably inevitable that not all of the capital is going to be spent if there are things that we see isn't necessary, or where our design leads us to believe we need to think more carefully about what the capital spend would be. It's better that we don't spend the money and spend it more effectively in another year than that we rush to just spend the full budget because we said that was our maximum figure in the first place.
It's not so much a question. I just wanted to flag up the depressing data that of the inspections carried out so far this year, we're still running at about a 20% non-compliance level, which is the sort of historic level at which we've regularly found non-compliance. So there's still a significant body of providers out there who are not when they are inspected, achieving the standards that whether they regard them as basic or anything else that we expect to see. And I think that, and these are people who will have been inspected at least once already. So every time it goes round, there still seems to be a significant base core of providers who are not achieving the requisite standard under the old system. And the other depressing feature really is the extent to which providers who are non-compliant are still, there's a core of them who are still non-compliant after a year. And that is not improving either. I'm not blaming anyone around the table. I'm just saying these are depressing features about the population of providers that we're inspecting.
And I think, if we're going to have a new form of inspection, we need a new relationship with compliance. Otherwise, all we're doing is a really better form of finding out what's wrong. And so there needs to be, we need some way of acting on non-compliance quicker. So that the residual, if 20% of people are non-compliant after a year in ASC and in NHS, and that continues in 2 years' time, when we're doing wonderful inspections and finding out things are wrong, that would be failure.
But Paul, do you think that having ratings will, of itself, be a bigger incentive for people who are not compliant at the moment to improve?
I think it will. I think it will show those people that have got the wherewithal to improve will worry about the ratings and will probably improve because of them. Those people that have not got the wherewithal to improve won't improve, and that may be 17%. You know, and so in a sense, you know, what do we do within a year? Because a year is quite a long time for organisations to be non-compliant. So this is just another general discussion around this. Around, you know, it would be rather a shame if we end up with 3 brilliant sets of inspections that then don't impinge on 20% of the care in the country.
Yeah, I mean, I think that's a really good point. I know we've said that we encourage improvement because obviously improvement rests with very many people, and ultimately it's up to the providers to improve. But you know, I mean, I have said this quite a lot, but I think we need some kind of clear improvement model, which kind of clearly defines our role and others. Because at the moment it's not that clear. I'm aware of various things that can happen within CQC and without CQC. And, you know, there's the failure regime and all sorts of things. There's a TDA and monitor. And it certainly from where I'm sitting, it's a bit confused. And you know, also, if you do get an improvement, you can get an improvement too quickly, so it's not sustained. So it's not a straightforward issue. But I just feel that we need to be able to, you know, define it more tightly, both what our role is and, yeah, it seems it's not clear enough at the moment. But at the same time, we have to be quite clear what our role is and what others is. Yeah.
I mean, our role is pretty clear. We are not an improvement agency. We are there to shine the light on what is happening, and the improvement has to be done by the provider. And if they can't do it, then it goes into the failure regime. Anna?
So I want to pick up on this point as well. And I mean, I guess I'd observe that we did have some really important discussions about the registered managers question a while ago and decided to take a stronger approach, which clearly seems to have brought some dividends in terms of the numbers of non-compliances in social care organisations over the last period. I don't know how much of the registered manager issue can take the benefit, but it seems to me that so I'm really glad that the executive are going to be looking at this over the next period, because I think it's going, you know, in the other two sets it's going the wrong way, and I think the points Paul makes are really key. I'd just like to ask that we have at an appropriate meeting and not too far away a report from the executive on what you've learnt by looking at these, about what the kind of the residual issues are and how many of these we could address by taking kind of collective actions on some themes which may repeat across these non-compliances, and what the kind of plan is for addressing them, because I think I take Kay's point about improvement, but from the public's point of view, what I want to be able to say is that where there's something which is non-compliant, and by that I would read, therefore, unacceptable as far as the public are concerned, that if they don't get it right, they no longer deliver that service, which does take them to the failure regime place. And actually, that's the harsh reality, but the one that the public need to know we're supporting by addressing these figures.
Just picking up on both those points, I think, can we bring back to a meeting later? Because I think enforcement is something I'm not probably as clear in my mind as I ought to be. Maybe we could have a paper in a couple of months' time which sort of picks up both Kay's point and Anna's point. Would that be all right?
I think that would be a good idea, and I think we should segment it as well. So one of the debates yesterday is it two inadequates and you're out? So there are some really important issues that are provoked by not just this historic data of what we're doing under the current model, but what that means as we go into the new model. And Paul, as ever, I think it's absolutely the right challenge to us about there's no point in having the most elegant, well-supported methodology that doesn't make a difference. And it plays to a paper that's later in our agenda on evaluation and how do we know this is making a difference and what is the difference we're making. So we have taken fixed penalty notices, but also we've seen a rocket in the acceleration of applications for registered managers. So the deterrent effect of doing something, and we need to capture not just the action that we are taking and what the outcome of that is, but there's a clear signal that people are behaving differently as a consequence of us saying this is what we're going to do. It's a good lesson.
Paul, did you want to respond to that before Lewis? Or?
Well, I just wanted to position that we're committed as an organisation to put at an enforcement policy, an updated enforcement policy in June, July time. This is largely in response to the changes in the regulations going through following the Care Bill. That we need to look long and hard anyway at our enforcement policy, just from the point of view of that sort of legal requirement, but it's the opportunity anyway to go sector by sector, build on the work we've already done with the NHS trusts in terms of the single failure regime and special measures, and work out what we're going to do equivalently in adult social care and in primary medical services, where the improvement bodies are completely different.
Okay. Lewis.
Well, that has almost covered what I was going to ask about, because I was struck by the pie chart on page 8 about enforcement and compliance reports, where the number of enforcement actions, I think this is a cumulative total for the current year, if I've understood it correctly, and the numbers in different sectors go 5, 16, 21, and then they go to 990. That's in adult social care, presumably. And I suppose there is a slight sense here of a sort of book where the final chapter has been ripped out, you know, what then happened, and also what were these 990? Because it's such a big number that it asks a question about what is the detail that lies behind that. You could say that some of the sectors in that pie chart maybe need a little bit of disaggregation as well, because the NHS is one of those sectors, and you know, you might want to know a bit more about how the NHS breaks down according to these enforced statutes. But it's really the issue is the one you're just touching on there, Paul, which is what then happens, and what is the story that we then can tell, accepting that we aren't necessarily responsible for the improvement itself.
No, that it's obvious, isn't it? Yeah. Thanks. Right, thank you. Eileen, you're doing a report on complaints?
Yes, indeed, thank you. Obviously, you have the paper in front of you. In the interests of brevity, I'll take any questions, but there's a few highlights and themes I'd just like to draw out. And it's fundamentally around highlighting that there has been much progress in terms of understanding how important complaints are to us, and really focusing on how we manage that function through and manage it well. But clearly much remains to be done, and it's to give you a flavour of what is being done that I think might be helpful. So we are doing a great deal of work on actually ensuring that complaints and concerns that come to us have a smooth passage through to the appropriate place for them to be dealt with, and that's actually a very important thing for us to make sure that things land in the right place in a timely fashion. And we are not there yet. We've made some improvements, but there remains quite a job of work to be done, and that's really begun and is being pushed forward. In terms of one of the first points of contact for us, which is through our contact centre in Newcastle, the NCSC, I think it's interesting to note that we've been undertaking some one-to-one training work with the people who are actually the first point of contact, the call handlers. And the interesting thing from that is actually the length and duration, the average length and duration of our calls is actually going up. And that's indicative of better conversations that are happening. We should celebrate the fact that actually we may not be hitting every target for a call being closed. I think it is because when we actually look, we're having better conversations with people and explaining things better, and our staff are actually saying that they feel that they are doing a better job. So I think that is a good thing to be happening, and we will be doing more of that. We are beginning now a review of our CRM system, and the reason for mentioning that is that CRM really captures and holds a significant amount of what we should know about where we are and what we're doing and who we are talking to, and allows us to have those proper conversations with people who may want to contact us with concerns. And it is not as good as it ought to be, and we are doing a great deal of work to actually understand what a fit-for-purpose CRM tool is for an organisation like CQC, and really working from the basis of what do we need and how far away are we from that. So that work has begun, I think is important in this context. We've touched on, in a slightly different way, the term experts by experience, and there's a note in here about some increase in the number of concerns being raised about experts by experience. I think it's important to note that sometimes we use that term and it's used to cover actually many groups of people who work with us on a flexible basis. So we do have our experts by experience who may be patients or carers. We also have experts who work with us who may have a clinical or professional background that we're seeking to draw upon. And we need to, again, as Paul would say, he uses the word segment quite often. We do need to segment and understand who we're talking about in this context. And Paul and I are doing a good deal of work on that in terms of understanding who works with us, on what basis, how we're training them, how we actually manage the quality of the experience that they're making when they're deployed into context. And again, that is very important as we seek to use more of such experts. We will need to be very mindful about, as I say, the recruitment, the deployment, the management and the quality assurance of that input. So that's a piece of work that Paul and I are beginning. We shouldn't underestimate what a complex undertaking is. But that's the sense of the work in progress, Chair. If there's any questions, please, happy to take them.
Any questions for Eileen? Okay.
Just a quick comment to say that having a sort of regular report like this to the board is really helpful. Complaints are often described as gold dust, and I think that's how we should see them. Because we're going to be looking at how providers manage complaints. So I think it's good that we're developing our approach, and we should lead by example. So it's very welcome.
Thank you.
Question, just on the, I was really interested in this new kind of complaints around special advisors and experts by experience, and people who, strictly speaking, of course, as you say in the report, we don't line manage, and but who are acting on our behalf. And I just wondered whether you could tell us whether these complaints related to the new style inspections, or whether they were part of a historic legacy.
I think they actually come from both, and that's why we're mindful that we're working with an imperfect approach, and we need to remember that anybody who is on an inspection is doing things in our name, and therefore the responsibility to make sure that there is high quality and satisfaction with the approach being taken is important to us, and that's very clearly what we're setting out as being the problem that we have to solve.
So I just observed that, I mean, given the scale of the new inspection teams and the fact that so many of the people on them, particularly in relation to hospitals, but so many of the people on them are not strictly employees, actually this is a potentially more significant risk going forward, and something that we probably need to think about in terms of how we manage the arrangements with those individuals. I mean, that's what you're doing, I think, but just kind of to clock it and say, actually, this is a significant risk, potentially.
I think, we all agree, really, that the risk is understood, and we are trying very hard now to embark upon bringing about a system where that risk is well managed.
Just wanted to reflect on the point that you've made on page 2 of the report, Eileen, about people feeling that the complaint that they've made about the service is not reflected in the inspection reports. And there's two things there, I think. One is how we feed back to complainants, and how we feed back more generally. To address this, because I think that in the main there is a kind of path that goes. There is a concern. It's fed through to the inspector. It does shape the inspection that we undertake, and one of the gaps I think we have is not necessarily going back to the complainant and saying, actually, here's the report, and being proactive about that. And for example, it was via Twitter, but I ended up having a conversation with somebody who had raised concerns about the service, was still worried about it, and that came through. And eventually I was able to point him to the reports that had been published, and he was fine because actually we'd addressed the concerns, but we'd obviously not told him. So I think that there is something, and this was the challenge that the Health Select Committee put to us about how we inform people of the outcome of our reports, and it is something that we're looking to address in our Wave 1 testing, to see whether we can write the summary in such a way that it can be lifted, cut and pasted, so that that can provide the basis of a letter to people who are using the service, so we can more proactively handle that responsiveness. So there is kind of wider work going on that hopefully we can build on.
And I think that's really helpful extra colour. I mean, the core principle is we are trying to ensure that we have a well-structured, well-understood approach to concerns, complaints and comments that come into us, so that people do feel a sense of engagement and that we are proactive about it.
Good, thank you very much, Eileen. Thank you. Paul.
We move on to the business plan for 14-15 and 15-16. So it's draft plan. Board has asked to comment on that draft. Note it's a 2-year business plan. If I start by saying it's deliberately not attempting to set any particular new direction. It's very much designed to be consistent with and provide additional detail on the 3-year strategy. And it will sit alongside a 2-year roadmap, which will focus more on the how we're doing things and just pulling together the story, if you like, for why the set of things that we're doing will add up to the changes that we want to see in the health and care system as regards regulation, and we want that to be a particularly public-facing document. In the interest of time, if I could just draw people's attention to 2 bits of the plan. So on page 6 of the plan, there's the organising framework that we use when we're thinking about impact and outcomes and quality and effectiveness. So that's ensuring that we always have the right measures in place. And it goes on to page 7 to look at the internal capabilities that we have in CQC as well. And then the more detailed success measures are on pages 27 to 30. And these are things I think the board has commented on in the past. But just to provide that link through not just into the actions and the milestones and the process, but how we think as an organisation we should be held to account.
Paul, it's worth saying, isn't it, that I think for our away day we're going to try and write the sort of the narrative that goes before this, and this is almost an appendix to the story, isn't it?
Yeah.
So there will be, I think we'll have a time to sort of discuss it in more sort of general terms on that day.
That's right. So we're expecting at least an hour for the conversation on the roadmap, as well as on the forward strategy and the state of care report.
So I mean, if people have got over the next sort of 3 or 4 weeks, if they've got some comments on this, I mean, do feed it into Paul. But any general comments today that people would like to make?
Just thinking of our earlier conversation about involving and engaging people who use services. I mean, it's not very clearly reflected in this business plan. So, I mean, we can sort of talk about it more when we meet, but I would certainly like that to be sort of have a higher profile and be sort of reflected maybe throughout. So it's just to sort of flag that up as an issue.
Let me take that one away, because we've clustered it in the priority 1 of the feedback for people who use services. But if it's not coming through enough, then we can do more. Thanks, Kate.
Anyone got any sort of fundamental issues they'd like to raise? And I think it's a good document, Paul. Actually, good. Anna, sorry.
Well, no, it's just that I know there's a link in this document, or there will be, to the strategy, but actually, when you go to the strategy, what you see are, I've just pulled it up again, the 6 strategic priorities that we've got. And then what you get in the business plan are 3 business plan sort of are they called priorities? Yes, 3 business plan priorities, and I'm just began to have the feeling of maybe we were drowning in levels and differences, and I just think there's something really, really important about simplicity here, using the same framework and following it through. So when I read the detail, it all made sense. It kind of, I know where it's coming from. We've had conversations about it. It involves the things that we've said we're going to do. But I just found it difficult to kind of join it all up in a way which made perfect sense. And I think we may have overcomplicated.
What we're lacking is one document which is coherent right the way through, which is the narrative and the business plan, really. And I think that's what we're working on, isn't it, Paul? That's a good point. I agree with you. Camilla.
Sorry, just one other point. Following the point I made earlier about the bureaucracy issue. I mean, I remember when, you were talking to me about coming onto this board. I mean, I suppose it depends who this is for. If you don't know much about CQC, it's very hard to understand what it used to be like and how it's going to be different. And I just remember somebody saying to me very early on, well, we've reduced the number of, we used to have X number of indicators and now we have far fewer. And I just think it would be nice to reflect somewhere in here that there's been a sort of more intelligent approach to monitoring. I mean, I know it says that, but it's not clear that what that actually means for a provider, and that part of the drive was to try and remove unnecessary, ridiculous compliance requests to providers. You know what I mean? Because I just think that would be quite reassuring. Because if you read this, all you can see is more and more and more pieces of paper landing on your desk. And actually, I don't think that's our intention. Do you know what I mean? I just thought it'd be nice to get that in there somewhere, that one of our measures of success is actually that we don't create compliance teams of 50 people in every organisation. Because that's not our objective, is it? Anyway.
Definitely not our objective to create those teams. In all seriousness,
I just really nice to sort of put it in.
No, I'm with you. The fundamental challenge, what isn't going away are the fundamental standards. So we have, and the DH draft doesn't really reduce the number of things that we need to inspect against. So
Paul, I think the point that sorry, if I can just, I think the point that Camilla's making is the point that Ed Richard made at Ofcom. Which is at some point, and we should do this all anyway, we will be judged on whether we're delivering good value. And that means removing costs from the people that we are regulating and keeping our own cost structure to the absolute minimum as well. Is that part of what you're saying? No, clearly not. You had to press the button.
I'm sorry, I feel I never kind of explained myself properly on this issue. I just think a lot of providers see us as a very top-heavy, unwieldy, bureaucratic organisation, and some of that report, and obviously that was the old model, said things like, well, it's untidy, we don't know what we're expected to bring, and I've been on, inspection, you arrive and they haven't got the papers together because they didn't know what they, all that, they wouldn't know what they're supposed to get. The new model is supposed to be much better. That's all I'm saying. So let's say that.
And it seems to be one of the outcomes. One of the outcomes could be that providers say they have to spend less time working with CQC, and that would be.
But this is what you've never been prepared to say. Right? This is what this table we've never been prepared to say. That'd be an interesting test. Can we say that?
Press the button, Camilla, because you're talking to yourself.
Sorry, it's great if we could say that, but that if we were going to measure that.
Well, I think we can measure that.
We absolutely can measure it, and we're here and we reflect that. But I'm also very conscious that we're not bringing 2 people into a hospital, we're bringing in 30 people, and we're asking for a great deal more data because we want to make a comprehensive assessment, because we didn't in the past. So what we need to reflect is the truth of what we're doing, and challenge ourselves to make it as least bureaucratic as it can be, as well as comprehensive.
Yes, and I suppose I'm not really talking about the NHS, I'm mainly talking about social care, where I think people feel rightly a bit fed up with the priority.
I think it's a great challenge, and I'm absolutely clear what you've said and why. And so on Friday, I spent 4.5 hours sat in with a registration assessor, and she showed me what happened from the call coming into Newcastle to what she'd got to do to issue a certificate. And on one thing, to change the registered manager of a dental practice, so to deregister the current and to register the new, I counted 50 clicks of a mouse. So it's absolutely spot on, and I think there is something in here that says about making our systems more efficient. Now, I think the audience for this is our inspectors and our key stakeholders. I think the narrative will be the public-facing document. One of the things I want to do with this after this meeting is send it to some of our key stakeholders and say, are you clear about it? So I think it will be read by people that have some inside knowledge. I wouldn't give it to me dad. But I would give the narrative to me dad, because I'd want him to understand why we're doing it. Not the detail of the measures. So I think there's a trick, and maybe you could help us come along. Paul pulled out the narrative at the front. It's Paul's team have worked on this. I've had no contribution to this, but I think just getting that graphic right about why are we here, what outcomes are we looking for, how do we measure it, and trying to pick up on your point, it's a good challenge as well, Anna, get the simplicity of this is what we need to do. And again, I don't want to put everything to later this afternoon, but there's the paper on evaluation, which is absolutely critical to this. I think the good thing is we're having these debates and they're transparent now and they're in public and we're forcing them through. And I think this will help us push into that much further, because ultimately, I tried to set this out in an internal note. You know, one of the issues from the challenge to Ofsted is how do we know we've made a difference? And we need to be able to demonstrate it. And we haven't got any time to start demonstrating that. The clock on that is ticking now. So I think it's a hugely, hugely important issue that we need to get right. And that's what we're trying to do in this without counselling perfection, to be honest.
Michael, have you got any comment on the business plan?
Well, I've only really got one. I mean, Paul's got a paper later today on cost-benefit analysis, which has actually got a slightly different framework from that on page 6 of the business plan. And I think it is quite important that especially the way we try and measure impact, which is the point that was just made, is consistent across these various documents that we are publishing, and of course that we hold ourselves to these measures. I actually thought the one in the framework in the cost-benefit analysis was probably, even though it was more complicated, I thought it was a more rigorous framework than the one on page 6, and I wondered if that should become the framework for the business plan as opposed to the page 6 version.
So what we've got in the business plan is an attempt to scale down the version in the fuller evaluation piece, but quite frankly, if it works better to have the full detail in with that, the one extra particular part around the costing model, for example, then I just take the board steer and we'll use the right one. Use the one that's clearest.
There are two. The narrative, I think, is the one that goes to that David's dad needs to. I don't know David's dad, but he's the one that, or your mum, and it needs to be able to understand the narrative. But what's behind the narrative is what I think we need for our own staff within the CQC, but also for the Health Select Committee and providers and the like. But we do need to have one coherent document which all ties together, I think. Excellent. Well, look, it's time for coffee. We'll have a break for coffee. Paul, the new approach to thematic activity?
So there's been a series of conversations at the board on thematics. Back in the last part of last calendar year, we had the overall discussion, and then the next board meeting there'll be a presentation on the suggested topics for the next 6 months, so Q1 and Q2 of 14-15. And this paper sits in the middle of those two. And is aiming to set out in a more detail what the principles of the new thematic programme approach should be. So the ask of the board is to agree the direction of travel. The highlights of the report, and I'll keep not trying to go savagely through it, are a suggestion that we dedicate 2.5 to 3% of the full operational resource of the inspecting directorates to providing this authoritative voice through thematic work. And that we think that would translate into up to 4 very significant thematic pieces in a given year and up to 12 smaller but still significant pieces. We've had a number of conversations about how the link takes place between the thematic work that I lead and the integration work that Steve leads, and there clearly is overlap, and Steve and I work really closely on this, and Steve's lead Matthew Traynor as well. But it's also worth teasing out the difference being that the thematics are national as a general rule, whereas the work that Steve will lead has a local flavour, so it will tend to look at the quality of care for an individual across a whole series of services in a locality. So quite clearly those two things can come together, but there is that difference. The other part is that although, by definition, Steve's integration work is about the integration of care through the eyes of a patient or person who uses services, not all the thematic work will necessarily be about the integrated care agenda. We may take a particular theme of, say, safety. So there's important differences but very linked programmes. If I could draw people's attention then just to 2 particular parts of the paper. If we look to page 5 and midway down, that sets out what the purpose is of the new approach to the thematic programme. And this follows the discussions at the board. So we think there are 3 things that should really determine why we're doing a thematic. So if it's just about telling people what's already known but codifying it, we don't think that's good enough. If it's something that lots of other people could do, we don't have a particularly authoritative position on it, then again we shouldn't be doing it because there's so much that we should be authoritative on. And if it just provides a running commentary rather than encouraging improvement as per our purpose, then again that's not a good enough reason to do it. So that's the purpose part. If we go to page 8, and the very top where we look at the proposed priorities for the 14-15 topics, I say we'll bring those topic shortlist in the next board meeting. But we think the 4 main areas to focus on for 14-15 are quality from the perspective of people who use services. Particular focus on safety. We would look at critical risks generally, but we think safety is a particular theme. We want to look at the care journeys across services and the integration of care, and we want to look particularly at the inequalities work, including people in particular in vulnerable circumstances. So to give the counter example, it is less likely that we would spend our time thematically looking at the effectiveness of cardiovascular services in hospitals, just as an example. It's important, it's not to be disregarded, but it's something that Mike can pick up directly through his work. I think I'll leave it there, but that's the main elements.
Thanks very much, Paul. It's really good to have a sort of a theoretical basis around how we assess what to do, and I think it's really important to do that. Are people convinced by Paul's paper? Lewis?
Well, I must say I think it's very good. I like the principles, the 4 bullet points that you just highlighted. I suppose the care across different parts of the system I think is critical here. I joined an inspection of a care home recently, and one of the main issues was the medicines management, and yet that wasn't what we were there to look at. It was about the GPs going into the home. So I think that's absolutely crucial. I think that's a key thing. I suppose there's another catch-all about other gaps in the system, which I think anything that doesn't fit our other methods probably ought to be addressed this way. What I'm not sure about is the role of the board. So, Paul, maybe you could clarify that. It seems to me that one way in which this system will work well is if there's quite a short lead-in time. I'm not quite clear what lead-in time you've got in mind, but it could be quite short. Sometimes the process behind clarifying the exact terms of reference of a review can get in the way of doing the review in a timely way. And there are other NHS-related organisations that have fallen foul of that over the last few years, I would say. I know. And you know, you can just try to spend so long getting the exact purpose right that in the end you've missed your timing. So I would suggest an early identification of topics, and maybe the board has a role to play there. It is written as if our role is to take the provisional list of topics from the Thematic Activity Strategy Board and approve it. Whereas actually I think we should have a stronger say, of course I'm bound to say this, in what the topics ought to be. We already were doing this online in response to the emails that came around. So can you assure me that we'll have an input into the topics themselves?
Yes, absolutely. So the email's already gone round asking for for views of the board on a much longer list, and it certainly shouldn't be just a tick box. Yes, that's all fine. If there's things to be proposed or debated that other big areas need to be included that we haven't got, we should do that. I'd ask if we could get those ahead of the main board meeting, just so we can do the necessary work on them in advance.
Just to make a comment, and it's a really helpful paper, Paul, thank you. One of the benefits of this, although I can understand that we wouldn't necessarily set it out as a purpose, but one of the benefits of this is how it helps us to improve our inspections on a kind of, you know, day-to-day basis. So the thematic kind of inspection that was done around dignity and nutrition, you know, and the one that was done around home care, there were some aspects of the methodology that came out of that actually very helpfully feed back in. And I didn't quite get that from the paper, and as I say, I can understand that we wouldn't be saying, you know, that as a primary purpose, but it would be really useful for us to keep that in mind, that some of the learning is not just for the sector but for ourselves as well.
That's absolutely spot on. And that we know there are areas of our ratings approach across the different sectors where we're more or less comfortable, and I think we should absolutely look to test areas where we're less comfortable to see what the standards of good look like through thematics.
I mean, I was going to make that point as well, but I just wondered if we could actually be very specific about that, particularly now, because we are developing fast, and I actually think it would be valid to make it part of the purpose. I mean, it can be reviewed, but given there's so much that we're developing, I mean, I'm interested in views, but I think there could be some merit in, you know, making that a core part of the thematic reviews, certainly in the short term as we kind of develop, and, you know, just a thought.
Well, just a general plea. I mean, I can see lots of values to thematic work, and the one described is another one which perhaps isn't properly emphasised. I've got some rather bitter experience of thematic work in an otherwise sectoral regulator, though, which is that it is always, not to say it will be here, but it is naturally a poor relation. When you are set up on a sectoral basis. And one of the reasons why it's really important that it shouldn't be a poor relation is that it's the place that you have the opportunity to look at the way things are in the round for people. It's a well-rehearsed argument around this table. That's partly about integration of services at a local level, and I appreciate the differentiation you've made there, Paul. But it's also about looking at these issues in the wider sense across the whole population and the whole of service provision, and that for me means there is a really strong case for us having a very good programme of thematic work, which is very heavily dominated by looking at groups of people and the way that the area we regulate delivers for them in the round. And I'm very glad to see on page 8 of that list of things, although people are rarely mentioned in the early parts of this paper, by the time you get here, there's 3 priorities which are very much proposed priorities, which are very much about that, and that feels right to me. But I guess the other caution I have around this is that so there's an issue about challenge for time in this programme and the extent to which the people user issues really are given enough space. And there's also a second challenge in this paper, which is about resource. because it depends not on dedicated resource, but on resource being provided from what will inevitably be pressured directorates doing the day job the CQC does of everyday inspection of all of these institutions. And I can just feel a kind of a pressure on priority and a pressure on resources. And all I can do is say, look, please let's be very, very careful with what is a very precious resource, and the way that we have always said we will compensate for the sectoral approach, which we have necessarily and appropriately adopted. But we need to protect it for for these things, and make sure that the time genuinely is available from the people who are in the 3 inspectorates.
I just wanted to again support the general direction of this, but particularly to welcome and encourage the clarity with which the difference that potential studies are going to make should be explained when they are put to the board. So I entirely support what Lewis said about making sure there is a wide spread of choices, but also could those choices then set out how the report, the outcome of the report, will benefit patients, users, the wider public, rather than simply being an interesting topic that we round the table might feel we would like to pursue.
Thank you very much for providing Appendix 1. Can you just put into numbers what 3% of operational resource equates to? Because I don't know how much that is.
About 45 inspectors.
Which is how much money? Roughly.
3 million quid, 2-3 million pounds.
Okay, because that is the opportunity cost of this, right? I mean, it's very important that this is not free resource. This is money that, we could be spending on other things, right? So I just think it's useful to have that in mind, because a percentage doesn't necessarily sort of give you that level.
And each review is 5 staff years. 5 years of staff time, right? Which actually is another way of putting that's a lot. And so, but I think what's been useful about the discussion is that what's been asked of you, Paul, is to come up with a set of internal outcomes, i.e., how will this improve our work? And your example about medicines management seems to be, therefore we've got to do things with that, because otherwise we're just making recommendations for other people to do stuff, which is the easiest thing in the world to do. And then they don't do it, as we found with everything else. So what comes out of these things, I think, has to be a part. Because actually, care journeys across services and integrated care, you don't need 5 man-years to explain it. They're bad.
Exactly.
Right? We know, right? And they may be very, very bad or just very bad. But actually, we don't need 5 staff years to find that out.
Probably do need 5 years to work out how to build it into the inspection regimes.
It is the critical. Is it worth doing? I mean, that is the point, isn't it? Just producing an interesting paper that no one bothers with is pointless.
Absolutely.
So I think that is the rider. If we're going to agree that 2.5% or whatever it is subject to finding something worth doing.
Yes.
Camilla.
Yeah, I mean, I strongly support this and the use of the resources, and I think it can drive how our state of care report really makes an impact on care as well. And I think it will affect everything we're doing to make what we're doing as CQC more meaningful. Just to take up an example that Lewis has raised about prescribing in care homes, because we know the evidence base on prescribing in care homes is that it's Tony Avery's work from Nottingham University, is that the errors break down roughly in sort of 20%. The doctor prescribing, the pharmacist's interpretation of the prescription, the care home, whether they give the right drug at the right time or whether the patient's capable of getting the drug. And it's an ideal example of how Andrew and I will work together. And this board supported me in doing a review of our medicines management team a few months ago, which is ongoing now, because we have a team of pharmacists which look across all 3 sectors which I house, which will need to expand. Now, that's the sort of an example of how a thematic might change how we inspect. And as we're building our inspection model for primary care from the bottom up, as we go into a CCG area, we will want to get more feedback from care homes and from users of the service, and we can look across sector all the time. Where Paul's leadership is really important is that these can be these will be national and have national impact, but we might test out with the work we're doing, and we might change what we're doing as the base of the thematics. And I see the board as being a really important part of this, to debate the priorities and look at how we can really have a massive impact on care generally.
This is a point I had thought of making when you asked me out of the blue what I thought about the 3 Chief Inspectors' reports. But I think Mike, Steve and Andrea, all in different ways, have, I think, suggested an opportunity, which is that if, over the next year, one of Steve's sort of clinical commissioning group areas is the same as the trust, one of the trusts that Mike is going to be inspecting in, what might be wave 2 or wave 3, and is also a locality in which Andrea is going to look at various types of care home and domiciliary care. I think the ability to provide this is what the NHS looks like, or the NHS plus private care homes looks like when we take a very specific area, and also it gets to some extent Paul's point about how this all works together. I think would be a very important subject for us to have, and it may actually even in terms of resources maybe it's really the makes up a third of the thematic work, because it is so important to give this overview of the system. And I think and only the CQC can do that, because it has these 3 very specific inspectorates. Quite a lot of the other work that that I think some of colleagues' suggestions, although all of it was interesting, other people are doing bits of it, and maybe in a position to do other pieces of work better, or at least the CQC could only do sort of equally well. But this is something that only the CQC can do, and we should have the skills to do it really superbly, such that there is very deep insight into, well, here is the system as a whole, and here's where we see problems, issues, need for reconnections, a different way of doing things, a whole range of cross-inspectorate issues. So, and I think if we could, I'd be very keen on that, as it happens to be a sort of centrepiece of the next State of Care report, because I think I'd add to Paul's criteria, they should be things that only the CQC can do. There's something about our knowledge that means that we've got special insight into whatever the thematic reviews turn out to be. But I am quite keen on this cross-system thematic review, because that just seems to me, having listened to the Chief Inspector's report, something which is uniquely, we do have just a unique capability.
I'm so pleased you said that, because that's the rationale behind why I'm here, to try and drive that particular agenda. I think we really have got a chance in a generation to sort something out using CQC as the key body for driving change, because this will affect commissioning, and we will clearly be able to look at how we commission. It's not just an issue of local authorities, as David rightly said earlier on. This is about commissioning across health in its various forms. But to just extend that some of the discussions we've had within the last 7 days with the Chief Inspector or HMI Constabulary, we should be speaking out much more about some of the abuses that are happening in health generally. For example, female genital mutilation, domestic abuse. We can work closely with our colleagues in other inspectorates to focus on important issues. And I see that as part of the integrated work. This is about the health in its broadest sense of the human beings who live in our country.
Michael, thank you for that. Right, Paul, are you happy with that?
Yeah. Thank
Good, thank you. John, the Audit and Corporate Governance Committee.
I think I can be very succinct on this, David, and say that I'm happy to answer any questions which arise in it or from it.
I've got one question for, if I can. The Gateway review that was done, which you obviously looked at in some detail at the meeting, I didn't read it to start with as close as I should, and formed the view that they were basically, we were doing fine, with a few caveats, and that was obviously an incorrect reading of it, because actually the criticism they had, or the risks they were flagging, you have felt were quite serious.
Yes, and that's why we've said that, and I've talked to Hilary about this, that the statements which are being prepared as a result of the Gateway review, which are basically the overall statement of what it's trying to achieve and how it's trying to achieve it, does need to come to the next meeting of the Audit Committee so that we can then examine that and report back to the board. And that's what I hope we should be able to do.
I think it would be really, if you could do that at the next meeting, just give the board assurance or otherwise as to how the transformation programme is going. I think that would be really helpful. Thank you. Yeah.
David, can I just check?
Yeah, Hilary,
the Gateway review that was done in November was an assessment of deliverability of the programme at that state in time. They made some really useful recommendations about our overall ability to define our end state and our progress towards it. But their confidence in our deliverability was a positive one.
Yeah. Okay.
Ask, could we be sent a copy of the report? Because I don't think we have had it yet.
Has it been sent round or not?
It has, but we can resend it.
Oh, sorry, I must have missed it.
Yeah, well, there's so much. And if you could resend it round, does everyone want to see it? Yes, please. Could you send it round to everybody? But John, if you could, if we could come, yeah, I mean that's obviously part of the feedback, maybe for the next meeting. Good.
Sorry, can I just? I'm just wondering whether I mean, because as Hilary quite rightly says, that was a report that was in November, and actually we've done a ton of stuff since November in terms of moving the programme on, both from the development of the new approach, the movement into the new
it's a reference point. It's just a reference point, and I think we've moved on from that. We all know we've moved on.
So I just think kind of reading it in that context will probably be quite helpful. That's all.
And I think the committee, the Audit Committee, would be very happy to have the explanation of how some of the risks which were identified in the Gateway review, which, as you say, was a few months ago now, have been mitigated to a greater extent than have been identified when the Gateway took place.
And we'll be doing that for the March board, and I'll also like to provide a sort of an end of first period report back to the full board on what we've done, what we're doing next. And we have a next Gateway review scheduled for June, July time next year as well.
But as I said, as I say in my report, the committee fundamentally supports the purpose of the transformation programme and recognises that it is central to achieving the changes which we need to secure for the Commission. But we do have, it's a big ask, it's a big challenge, and it does need to be kept on programme, and both in time frame and the breadth of what's being achieved. And it's a really difficult challenge.
I think we should see this as being a really helpful piece of work to just get John and the committee to just do a check, because whilst we did get the Gateway review, I think I said to the board it was positive, because that's what the principal reviewer said to me when she debriefed it back to me. That said, John's point that he's just made about this is a massive programme and the degree of risk in it. We've just changed 1,500 people's jobs. Michael has often said we're going to take on 500, which is as big as taking over another organisation, and we're doing that simultaneously while we're changing every method we've got. So actually just being open about how we're mitigating these and how we're dealing with it, and having a really open conversation in detail at the Audit Committee and then reporting that to the board, I think will do nothing but good. So we should actually go at it in that spirit, I think.
Thank you. Michael, the Governance and Value Committee.
Well, John very kindly chaired the committee in my absence, but I think the committee had a very good meeting, and I think there's a pretty clear programme of work ahead for the committee. And I think Claire's minutes, I think I discussed this with John, sort of accurately describe the last meeting. So I'm happy to have any questions to John and myself. But
one, Michael, if I could. I mean, the patient complaints and raising concerns are a big issue, and we're generating quite a lot of debate, particularly around whistleblowing and raising concerns at the moment. And we do need to bring our stance to a conclusion at some point. I mean, how far? I know that we've just instructed Kim to do some work for us, haven't we? But when do you think we'll be able to bring it to a conclusion?
Well, we've also commissioned these two external reviews, which the CQC was, I think, committed to undertaking. So I think it's going to be another 2 to 3 months before these various reviews are finalised. But I was unfortunately, I had to cancel it going to see Eileen this morning because, as you saw in the paper on complaints, this is a very integrated set of issues and set of challenges, and we do need, I think everybody agrees, to come up with a CQC way of understanding and using complaints and whistleblowing. And I think, the one conclusion, I think, of the Regulatory Governance Committee is that there is a very small distinction between the two. Having said that, I went to, as David did, the whistleblowing event that Kim Holt and James Titcombe held. And I think there is undoubtedly pressure and a feeling that the CQC may be able to be that point in the system which really does provide support to whistleblowers, such that in a way whistleblowing becomes such a normal state of affairs that it does actually transform itself into a just culture, which David's described. So it is a challenge for us, but the end point of the challenge, would be, a very good place to be, because, as I say, it should move us towards encouraging cultures in the providers that the CQC inspects, which means that we might actually be able to abolish the term whistleblowing, or have a term which more accurately describes what we really do want to hear from people.
I'm just conscious the Health Select Committee are doing a study in whistleblowing and raising concerns at the moment, and they've asked us to submit evidence by March the 17th, or sometime in March. So I think we'll need to submit something at that point before then. So, Michael, I wonder if we could ask, if we draw up a draft for you to look at. I don't think your committee is meeting before then, but maybe you could circulate it around to people and get their sort of sign off on it. Andrea?
And just say it is something that we are thinking about across the sectors in terms of how that's been taken into consideration in the lines of inquiries that inspectors will have. So, how are organisations listening and responding to the concerns of staff and anybody else about the service, including whistleblowers, but actually trying to get in the language that we should be listening before people kind of, become whistleblowers, because actually it's responding in a much more proactive way that needs to happen. So I think that there's probably something that can feed in on that, and the work that Malta and Paul's team is doing to make sure that that's consistent across all three of us, I think would be important too.
Thanks. Do you want to do that?
So David, just to set the work that Michael's overseeing through the committee in a context, Permanent Secretary in the Department of Health was asked by the Chair of the Public Accounts Committee a question about whistleblowing, and in answering that, the Permanent Secretary gave an update, and then we've been asked to make a statement to the Permanent Secretary, which will then be sent today, I think, to the Chair of the Public Accounts Committee. And in preparing that answer, this issue about precision of definitions has come out. So what we did have is, following Winterbourne, is a whistleblowing hotline, which has been redefined as a safety escalation hotline, because we were counting, and I think this is where some confusion had come through, calls to that helpline. And I think when we're in Newcastle, a number of you sat by people taking these calls and listened to them. And we've quoted figures 7,000 and a few and 8,000 and a few for last year and the year before that. And I think that's been interpreted in some quarters by some people as being there's 7,000 and 8,000 whistleblowers. I mean, actually what we've had is 8,000 people raising concerns, of which some have been whistleblowers. And the system we've got is that colleagues in the safety escalation team up at NCSC track those cases through, and we're clear about handing them over to an inspector where they end up. And what's been clear from preparing the answer, there are a number of cases where we've not recorded on our customer record what the outcome of those cases have been. I'm told that they have been followed up, but of course if there's not a record, there's no evidence that they've been followed up. They've all been triaged, they've all been passed through. The issue isn't that they've been left untouched or unacted upon, but it raises the issue of where have they gone and what action has come through on them. There is a smaller number of these which are whistleblowers, 500 and 600, I think the precise numbers. I can set this out in a letter if it would help. As I say, this is something that's just happened over the past few days. So as we develop our methodology, we need to make sure it's not just our policy and strategy that's right, but the detailed operation of this. And I think we need to be much clearer in breaking down the numbers into what the nature of the concerns are and what the action has been to follow them through. So those which are genuinely whistleblowers, in the terms of these are employees who have made a declaration to a designated body, and they are then protected by what is effectively employment legislation, that their employment will be protected, as distinct from people that are raising concerns, whether they're employees or staff, about the quality or safety of care where action is required. And I think we need to do more, to use a phrase from earlier today, to segment those numbers coming through, and then we can be clear about where they go to within CQC and what action we take in relation to each one. So we need to log them and track them through. I think one of the things that we are going to do, because of the uncertainties that we now have in relation to a number of these referrals, is to do some audit work to check on a sample of these to make sure that we are confident we know what's happened, and we'll put that arrangement in place and report back to the board. So the purpose in raising it is just to make this absolutely transparent, that this is something that's come to light as a consequence of answering a question. We will include this in the evidence that we send into the Health Select Committee, and once we've drafted that evidence to go to the Select Committee, we'll set that in a separate note that will go to Margaret Hodge. We do know the NAO are going to do a review of CQC sometime during the year, and I think we should anticipate, whilst they don't all go to the Public Accounts Committee, we will end up going back to the Public Accounts Committee before they finish their work during the next parliamentary term. So we'll continue to make this transparent as we begin to work on not just the strategy but the systems and processes that we've got in place to deliver that.
I sort of feel uneasy in this area still, to be honest with you. I think that in between inspections, the absolute key source of information that we're going to get will be patient complaints and staff raising concerns, and we've got to have a system in place that deals with them really effectively, and we can demonstrate that we're dealing with them effectively, as well as a strategy, if you like, for listening to people better and enabling people to raise issues in the first place. And I just don't feel that we're quite there yet. And I rather glibly I've said, well, we have a hotline in Newcastle, but without actually really digging down to see how effective that is. I think we do need be real assurance that is working well. And whether, Eileen, I know this now comes with you, doesn't it? Whether you could, in maybe the next meeting or soon, give us some assurance that how it is working, please.
I also recognise what you're talking about. We are embarking, as I talked about earlier, in terms of complaints, about bringing together a much more coordinated way of working, and Paul and I share an interest and a footprint in this area, so we are trying to make the coordination work. I suppose we want to go from a point of actually wanting to encourage people to see CQC as a place to come to, for us then to being able to capture and work through and evidence what we've done, and then to learn from it. There is a virtuous cycle to all of this work that we really have to make work for us, and we are away from it, David, but nor are we completely broken, and I think we are somewhere between the two, and it's that journey that we are embarking on, and there's a whole set of activities that need to happen to make it work, and certainly can come back and talk about, and I'll be talking with Michael when we're able to sit down together just about how we do make all of these components work together. But there's an issue of philosophy, which is about we welcome and encourage, and then there's an issue of practicality. What do we do, and how do we track outcomes, and how do we ensure that we learn and systems learn from what is coming through the door? And that's bigger than me. It really is an issue for all of us.
I think Paul wants to come in, David, but I think it's Paul and Malta that need to lead on the policy development of this, and then we'll hang the delivery and the implementation off that. I think what my briefing is doing is actually saying there is a disconnect in terms of when it leaves NCSC, the stuff that's going on in NCSC would appear to be fine, although there are some definitional issues that we need to tidy up. At the minute, what we've got is one place where all concerns come. They effectively triage them, but they then need to be handed over to an inspector. So it's at that point, I think, that we need to be absolutely clear what people are doing with it and how it then informs any reactive inspection we have, whether that's a reactive inspection of a hospital because there's a clinical concern or it's a reactive inspection of a care home. And I think what the figures are exposing is it's that bit of the system that we actually need to attend to. The other issue we've got, I think, to attend to is how we define things as safeguarding as distinct from quality issues that we need to address. So if we just need to be absolutely foot sure that we're clear about what action we are taking on the referrals, and we aren't handing off to anybody else the responsibility for something and we're taking it. I think it fits to some of the earlier conversation, to be honest, about clarity of role and then clarity of action that we need to take once we've accepted something and we need to act on it. But I think Paul was going to.
So there's a big link, I think, to the paper that's coming to the next board meeting around unexplained deaths in care and other serious safety incidents. Because the challenge for us is to say what are the events so serious that we hear about they will automatically trigger a piece of regulatory action, whether that's an inspection or otherwise, versus the professional judgment we give to our inspectors to say there is a massive evidence and somehow they weigh that collective evidence up to make a decision about whether to bring forward an inspection or contact the provider in some way. This, I think, will vary to some extent sector to sector. I think it's a really important piece of policy work that we do so that we can give clarity to our inspectors and probably more importantly, just clarity to the public on their confidence, so they know when we're going to act. And of course, the backstop position is how could we not, if we decide not to go in on the basis of a single incident and something awful has happened or happens in the future, then we're rightly going to be held to account for that. So I don't think it's something we can just leave floating, but it's a proper and significant piece of policy work, whether it's a whistleblow, whether it's something from a member of the public, or whether it's a death in detention or other serious safety incident.
This is an issue I discussed with Jennifer Dixon. I should have said at the beginning, apologies, she's away today, that when the whole Healthcare Commission was working, they had some pretty clear guidelines that would have, of how you would, if you like, triage what you do with information. And I think, I mean, I've been 2 cases recently where whistleblowing complaints from a particular hospital. Are they serious enough to justify an immediate inspection, or do you wait for 6 months and do the inspection in the normal course of events? And of course, if you decide not to do an inspection, then something awful happens in that place. So I think we do need to have a system in place, which I think is what your policy is going to address, Paul, isn't it?
Yeah, exactly.
I mean, I think the board needs assurance that when issues are raised, that they are dealt with in a certain way, and there are certain thresholds which might or might not trigger an inspection or something else. Yeah.
I don't want to complicate because I think you're exactly right that we need to be on top of this, such that what's coming into the CQC is properly used and responded to. But I just think it's worth, and this is certainly something we've talked about at the Regulatory and Governance Committee, is that there are, in a way, 2 questions here. One is about making sure that we do what we are supposed to be doing right now better and well. And I think what David is kind of describing in terms of making sure that what happens in Newcastle kind of gets through to the right people and the right actions are taken is absolutely about. We've got the front end. We need to make sure the rest works efficiently and effectively, and we can put our hands on our hearts and say we've sorted that. There's a kind of different question which I think it is right to take a slightly longer term approach to, which is that there is a big piece of work in the wake of Francis and Clwyd Hart and all of those reviews, which is signalled in Hard Truths, which is about, well, so what should this system look like across all of the system players? And that should, I would hope, mean that in the future there will be a clearer sense of what CQC's particular role in complaints is, not just what we do with what we get in through our front door, but what our role in that system is, and what we're saying to what we and all the other agencies who have a part in this should be saying to the public about how they negotiate their way through the system and what support is available to them and so on. So that's a kind of bigger thing, and I think it's really important because it needs to be a system-wide response, that we do that with all the other agencies, which means doing it over a slightly longer time frame. So I'd really counsel, yes, as you say, let's do this, but let's not run ahead of everyone else and redesign everything in a way which makes assumptions about what our role in the overall system should be.
So just one other point, which the Regulated Governments Committee has discussed and which Eileen just touched on, the extent to which the CQC should actively encourage employees of providers to come to us. It was interesting, and it wasn't described in any detail, but I think in the inspection report on the Royal London Hospital, it said that three whistleblowers actually approached, three whistleblowers approached the inspection team. So I thought that was, a very interesting point, and whether that's something which happens regularly during inspections wasn't so clear, but it may just have been pointed out because of the person who wrote this particular report. But it would be interesting to know what sort of issues these whistleblowers did raise.
I can't specifically remember for that report, but it is just worth pointing out that with the Colchester issue, it was a whistleblower at the time of Bruce Keogh's review that highlighted the problem with recording of waiting times, and that led the CQC to inspect specifically on that point and to investigate it, which then ultimately led to Colchester being put into special measures. So it's not unique that it's happened at one hospital. I think I should take that one away, and actually we ought to look into it. I'm not aware of it happened. I think, what is a whistleblower? There are concerns raised. If you've got a focus group with 26 consultants in a room and every one of them raises concerns, which in some places they do, are they all whistleblowers, or are they just informing us about what's going on in the hospital? So there's a difficult balance.
Yes.
Tiny point. I totally agree. We need to improve the linkages. I just wanted to say, I think most of us who went to Newcastle and sat in on the phone conversations were really impressed. And I think those staff are doing, the ones I met were doing a really good job, and it's a difficult job to do. So I just wanted to sort of say that in case anyone gets the impression that they're not, because it's not really, it's not they're doing a good job. It's a question of where the information that they're getting goes, isn't it?
The last chapter not being written again, in a sense, where do they end up?
I think, if I may, David, that would be really well received. I think, Camilla, by colleagues in Newcastle, who I think have done a fantastic job to actually, just raise CQC's game in this respect. I think the issue is our definitions. So it's not just as a short and a medium term thing. I think there's something in between, which I hope the RGV will help us on, which is, Mike picks up that point. A whistleblower legally has claimed the support of the employer under the legislation. And I think we need to respect that and listen to all whistleblowers. It's a really tricky issue about whether we should believe all whistleblowers. Many whistleblowers would say we need to believe them. So I would say the argument is it believe or is it listen? My personal view is we need to listen to them. But there's a lot more people that are going to raise concerns, and I think we need to be much more forensic in our policy developments and then in the delivery of our practice about just distinguishing things which come in as a whistleblowing concern because people want the protection of the legislation, the anonymity that can be afforded through that, and people who are quite happy to say, I'm person X in this organisation, I've been trying to raise this issue for years, I've got absolutely nowhere, I'm prepared to go on the record, I want to raise a concern. going straight through to people that are making safeguard referrals, which will mean it will get quite confusing between what does the local authority have to do in terms of their actions, what do we have to do. And I think that's the bit that we are challenged on from the kind of experience that has come through, and whether we're tracking each of those with precision. Because the difference between something as a concern that drives an inspection and a very formalised procedure for a safeguarding concern, which will go into a local authority, which will just get a whole architecture rolling into operation of what needs to happen at a local level, is really the point that we need to be clear of. So it's, and that those colleagues in the NCSC who are doing that triage at the front end need our help on those definitions so they can get the triage right. And I think that's the thing that's raised out of the data. And once we've done that, our track and trace system needs to support those definitions. At the minute, it feels a bit amorphous of what comes in. It's almost anything that comes into that phone line is defined as a concern, rather than the triage assesses them and then, in a sense, catalogues, defines them in some. There's an initial catalogue definition of it, which then triggers what will be slightly different action for each of those. But where the gap in our procedures at the minute, our practice is, we've not logged what the outcome is in them all, and that's the thing that needs to put immediately right. So we will put that immediately right from next week, that they must all be, there must be a mandatory field which doesn't allow any of those to continue into the system without it being. So we've stopped that happening. We'll look at the 3,000 where we're not clear, and that will be the audit. But the longer term piece of work is a clarity of definition. I'm sorry to labour it, David, but I just want to be clear what I'm saying. I don't want it being misconstrued in a open session that I don't want board members not to be clear.
Just to say a helpful input to that, maybe work that Bill Hodson, who's our National Professional Advisor on social care, has been doing with the Local Government Association and others around defining roles and responsibilities around safeguarding, which will be coming to the executive team shortly. So, so there has been some pre-existing thinking that might help with that as well.
David, sorry, I don't want to prolong it too much, but can I, or at some point, could somebody explain to me who takes responsibility for these? Because at the moment we have a system where the alert goes to an inspector who is a generic inspector. This is the old system, a generic inspector who has a portfolio of providers, and they have to exercise continuous oversight, surveillance, as well as the monitoring system of their portfolio. Now, I don't understand, and there's no reason, in a sense, why I should have that understanding automatically. In the new system, where we have specialist teams who go and inspect something, who holds the residual oversight judgment of an alert coming in and deciding whether to do something about it?
It'll be the same, John. It'll still go to the inspectors. So the issue, though, I think, is once we've got these definitions sorted, is what's the managerial oversight to that. But we still expect an inspector to have a relationship with those people within their caseloads. But I think what we need to be is much clearer about what the role of the manager is to support those. And one of the advantages of having more resource and more staff is that some of these big management ratios that we've had, where some managers have had 20 inspectors that they're overseeing, we're shrinking those down so there can be a greater support and oversight from the managers to those practitioners. You could argue that some of these things we've delegated too low in the organisation, and that people have felt unsupported with that delegation. And the debates we've had here about the structure and the numbers, which we've touched on, have we got enough staff to do the thematics work, is to ensure that staff are supported by their managers. Yes, there's an accountability to the managers, but they need supporting, because a number of these are desperately, desperately difficult. So the decision on following up the whistleblowers at Alderhay was one that me and Mike took. So we'd even taken it away from the regional director, their managers and the inspectors. And we said, I'm sorry, this needs to take place and it needs to happen before Christmas. I know that's tough, guys, but I want you in before Christmas. So 22nd and 23rd of December, they were in doing the inspection. They would have preferred not to do it. And we said, you need to do it. So I think we need to flex this on the delegations, depending on what the significance of the issue is that we're dealing with. And that's what we need to make clearer than it has been, because it feels a bit intuitive at the minute rather than it's set out clearly.
It is intuitive at the moment, which is why I think this policy paper from Paul next time is very important, precisely for that issue. Steve, unless you're desperate to say something, I think
I am, because we haven't talked about primary care, and it's my duty to raise that. And so we're starting to get an increasing number of people who are raising concerns about general medical practice, particularly the ones we've had recently in single-handed practices. And we've had a few of these. And the problem in a single-handed GP practice is often the owner, the registered manager, is the GP. And another family member might be either the nurse or the practice manager. And therefore, if people raise concerns in a very small entity like that, it's actually quite difficult for us to say, are they a whistleblower? Well, what's the effect of that person within an organisation? David and I have been having conversations about this because they have either triggered visits, or a visit, an inspection, has triggered more concerns from a member of staff who now finds a way of expressing themselves. And these can be quite serious. And it's quite difficult then for our inspectors to write a report with information, and also very difficult for us sometimes to defend ourselves when we're making a decision. So we're finding it a very sharp learning curve in general medical practice. And we do need to sort out this handoff so that people are taken seriously, and the taxonomy would be really helpful. And we need that information, because in some small GP surgeries, if you go on NHS Choices and other patient evaluation websites, they might have 5 stars and everything's wonderful from 2 or 3 patients. But actually, when you talk to some of the staff in confidence, they're worried about quality or cleanliness or whatever. I won't go into detail, but you can see what we're looking at, and that's why I wanted to say something. I apologise.
Michael, it's a big issue. It's difficult and complex and very nuanced, this. We do need to pull it together at some point. But in the meantime, Paul, I think that policy you've got there will be really helpful from the board's governance point of view. And we'll put together a submission to the Health Select Committee, which we'll circulate to the RGV Committee beforehand. Right, thank you for that. That was a helpful discussion. Anna, Healthwatch?
I'll take any questions.
Right. The board forward plan. I don't think we need to discuss that, do we, Eileen? That's.
Can I just ask, though, that the board forward plan gets kind of filled in more fully? Because there are a number of things which we've come back to again and again, which is really boring for everyone, but it's because we haven't recorded them as coming forward at a particular time.
We're going to have a complete relook at the board and how it's used properly and more effectively from going ahead from April. I think there's a number of improvements that we can make. So can we pick that up in that context? Thank you. And
Can I just do one thing?
Any other business, David? Yeah.
Yeah, so the any other business, between 9 o'clock this morning and 12:15, Dr. Janet Williamson, who's currently the Director of NHS IQ, has told her organisation that she's our Steve's 3rd Deputy Chief Inspector. So it's Janet Williamson that will join us to work with Steve as Deputy Chief Inspector, covering the Midlands. So that's Andrea with 3 Deputy Chief Inspector, Steve with 3, Mike with a full set of 4, so we've got 2 more to recruit. So that's good news, and I'm pleased that she's now just done those clearances and we've done the due diligence. So that's good news.
Thank you. I mean, just to be clear as well, she'll also be the national lead for dentistry, and we'll have a dental advisor working with her, and I think that's important for the dental sector to be aware.
Any other business that for? No. Any questions from the floor? David.
Yeah, I just wanted to come back to the question of consistency in inspection. I'm a user of GP services, of course, and perhaps rather closer to being a user of the other services than some members around the table. I'm worried about consistency because what I want is for you to make a difference, as David was saying earlier on. I really don't care whether you're making a difference in services I don't use. Consistency is fine if all things are equal, but the danger, it seems to me, with consistency is that you will say, shall we say, that you will not go into a care home in the middle of the night because a care home at the similar level of adequacy wasn't visited in the night. That sort of thing. So that really worries me about that. The only, in fact, so really I'll ask you what you feel about that you should take this sort of the user's point of view into consideration. It's one of the best things, I think, about it, the new CQC, is the way that you put the user first. The only kind of consistency that I really would like is if all providers, at least in the social care sector, should understand that the CQC will look with a benign eye on the installation of video monitoring. Finally, I wanted to say that in Westminster, which is my area, the links between the CQC and local Healthwatch are not as good. We are not receiving the reports consistently from CQC inspections. I wonder if something can be done to improve that. And finally, going to cross-system thematic inspections, can Westminster be the first place to have one?
David, thanks very much. I mean, Andrew, do you want to respond to that, or do you want to pick it up outside the meeting?
No,
David?
I'm happy to respond and to pick up the points, and thank you very much, David. In terms of essentially what you're asking is, what does consistency mean? And I think that what consistency really means is, can we be robust about the judgments that we make, and so that if we're looking at a service in one part of the country and we're looking at another part of the service, same service in another part of the country, we've got the we can be assured that a similar judgment should be reached. It doesn't mean that every step of the way to get to that judgment has to be exactly the same. So if we go back to the point that you quite rightly made, which is we are here to be on the side of people who are using services and to be as diligent as we can be to make the right and proper judgment, if actually that means that we need to actually visit the service at a different time, or we need to expand the time that we spend doing the inspection because we want to look at something in more detail, or whatever it may be, then we will have the flexibility to do that. But it's about using all of those different inputs to get to a consistency of judgment. So I hope that that's helpful. As you know, we are developing a policy position around the use of surveillance, and we will be in the next few months, and it's just taking time to set up, but doing a roundtable looking at the use of cameras and what is happening in care services, and it may well also be things that Steve and Mike are thinking about as well. So I can't give you any guarantee about that one now, but you know that we're actively looking at it. And I can't talk about whether we'll be going to Westminster first or not, but I'll leave that to others.
Anyone else wanted to raise an issue?
Thank you, Chairman. Could I just express my thanks to the board for taking questions and for including them in the minutes of the meeting. I have actually two questions, if I could bring one first, which follows the recent conversation about input to the board's information services. I'm from Hertfordshire, And there are many patients in Hertfordshire, many cancer patients and other patients who are not receiving clinic appointments from their hospital. If a patient reports either via the website or via the phone line that concern, firstly, is there a different pathway for the two avenues? And what, at the moment, what happens next? And how long does it take for anything to happen next?
Good question. Mike, do you want to answer that?
I mean, I think the first thing is if somebody is not getting an appointment, have they raised that with the trust itself? I mean, because that is the appropriate first channel. If they've tried to their best to get an appointment through the trust and they've not received anything, we should then certainly raise that. And again, in line with the discussion we've already had this morning, we should make sure that our relevant inspection people on the ground are aware of this. They can then make contact with the trust and find out more about it. And if we need to do an inspection, we will, but it may be just a question of getting in touch with the trust management.
Thank you. The other question relates to inspection of hospitals and the listening events. I attended a listening event for UCLH, which I found very helpful, very constructive, and the opportunity to have a confidential conversation, very helpful, which I took advantage of. Is there an avenue for feeding back to patients from the inspecting team their outcomes?
That's a really important point, actually, Mike. We discussed this with Ofsted, the way Ofsted feedback to parents and schools and to children, indeed. But Mike,
I mean, we certainly haven't as yet got a process for feeding back to individual people who've come to those listening events. I would hope that the concerns that are raised at those listening events would then be reflected in the overall report on the trust, not necessarily individually, but we heard concerns about people not getting appointments for outpatients, let's say, or whatever it may be. And then what did we find about that would also be in the report, because we would have... Outpatients happens to be an area that we look at as a core service. We would have probed that further with the outpatient managers or whoever. So I mean, we can take this away and think about how we could best do it. But I think at the moment, I would hope it would be reflected in our overall report. But if it hasn't been, maybe you and I can have a word with them outside the meeting about what didn't happen or might have happened better.
Well, I just there's a little bit of a theme, I think, in a couple of questions that have been asked from you both, which is the extent to which we expect people to find this information on our website and kind of, as it were, pull it, and the extent to which it's made easily available and pushed to people who might want to know. So I think the question really is, if I've been to a listening event, will someone simply send the relevant report to everyone who's been to that listening event, whose contact details we could collect at the listening event, such that they know as a matter of course, rather than expecting them to notice it's been published and go to the website. And by the same token, I think the thing about local Healthwatch and inspection reports, and I don't honestly know what the policy is here, the CQC policy is here, but you know, they're all available on the website, but do we expect local Healthwatch to always look before they go in to anywhere, for instance, to do enter and view or do a piece of work to see whether there's been a report, or do we automatically as an organisation send relevant inspection reports to the local Healthwatch in that area? So as a kind of a activity here, perhaps thinking about how we get the information to the right people in a timely fashion.
and a useful comments. First of all, in reverse order, local Healthwatch should, of course, be at the Quality Summit, and will therefore have heard directly about what was found at the inspection, and should undoubtedly get the report, but they will be hearing it firsthand, if you like. I think we should take away your idea of, at each of the listening events, getting a list of particularly email addresses of people who want to get copies of the report. If we could take that away to our design and delivery board, I think the answer will be yes.
I think the specific example that David was mentioning actually is social care. So it's not, which means it's not in the new system. It's still part of the old system. So you're right about local Healthwatch and hospitals. I take that entirely, but I think it's a wider question.
And I have written myself down an action point.
Good. Thank you very much for raising those questions. I think we're going to break for lunch now. Can we start again at 1 o'clock, please? 35 minutes. Thanks very much.